Now just go back to your screen back there. And then just make it bigger.
To fight this, I just have to.
Well, normally I would be able to.
I don't know. It is not like it
You were
used to be.
just called to. So there you go. You got it. Looking at you now.
Oh.
You got it. You got it.
All right. Well, why don't I?
And I still.
Well, that makes me feel better. At least I can see their growth in the future.
Yeah, I have tried to, couldn't do it freehand.
Yeah, how about that?
Everything good now, Dr. Berger?
It's suitable. I guess.
Suitable? Okay.
All right.
Take a deep breath.
Feel good. Saying whatever. Okay.
Okay, we have everyone
Do you
and,
want to test? Make sure.
yes, absolutely. Does everyone have a mic
Is the
on?
audio? Do I need to have?
Can someone on Zoom confirm that you can hear us speak, please? Dina or Dr. Hasty, someone?
Yep,
I can hear you.
Okay, excellent. We can hear you as well, so that's good.
Can you hear me?
Can you hear Dr. Berger?
Yes, we can. Sure can, Doc.
Can you hear me now?
Yep, we sure can.
Okay.
I
Do
think
you
we're
want
good.
to?
You let me know when you.
Yeah, but we'll just roll with it. Okay. Well, hi, everybody. Appreciate you letting me talk tonight about something that I'm very excited about, and I wanted to be able to hopefully share some enthusiasm and perspective and hopefully encouragement. As I was thinking about what to call this little presentation, I thought Pinedale Hospital Pioneering. And then the subtitle, particularly as to me, has the punch, what we get to do. And I think most of you know, I'm Dr. Larry Berger. I'm the director of the hospitalist program here in Pinedale. And I'll give you a little bit of information on my training and practice and biographical info. I was trained in internal medicine at a large tertiary care center in upstate New York with extra training and practice experience in cardiology. They can't hear me, right? Is that, yeah, okay. And I've practiced both in clinic and hospital, of course, hospital only now. Most of my career has been in rural medicine, and most of that has been in critical access hospitals. And in that context, whether it's inpatient or outpatient, I've had I think, an unusually high proportion or concentration of complex patients. For the last 10 years, I've had the privilege to mentor under the guy that coined the term evidence-based medicine back in 1990, a Canadian physician named Dr. Gordon Guyatt. And the only rural evidence-based medicine workshops that he's ever given are the ones that I founded and directed when I was in Ellensburg, Washington. I was also, when I lived in Washington, a member of the 11-member Washington State Health Technology Clinical Committee, where we would review the evidence for or against coverage for state insurances for certain procedures. I have a passion for education and outreach that includes medicine, but goes beyond that. In 2018, I started a music outreach called Learn from the Masters Music Outreach. There's really unusual opportunities working with world-class musicians as well as local musicians. And the mission statement is to reach the hearts and relationships of people and communities with the healing power of music. And it's LMMO, we just call it LMO because that's easier to say. And then in 2022, a couple of colleagues and I founded a medical education outreach known as EBM Truth in Medicine, or EBM TIM. And the goal there is really to serve as a teach to think tank, equipping people in healthcare, outside of healthcare, to make evidence-based healthcare choices. We've had the unusual opportunity to have Dr. Guyatt be one of our advisors, and the other one is other advisor is Dr. Prasad, an East Indian neurologist, international luminary in evidence-based medicine. By the way, if you're not familiar with EBM, is just the shortened version. So if I use that, that's what I'm referring to. But I thought it'd be helpful to know a little bit about me personally. I was born in a town in South Dakota that's smaller than Pinedale. My great-grandfather came from Norway, Knud Olsen, and homesteaded in South Dakota. I grew up in North Dakota. My wife, Christine, who is over there, is a respiratory therapist. She actually has family roots in Wyoming. And in fact, many years ago, her grandfather was a pastor here in Pinedale. So she has wanted to move to Wyoming since she was a little girl, like earliest fond memories. And so when Dr. Klein, my Division I president who flew in to be part of these events, called me about this, we jumped at it. And without exaggeration, I consider this to be one of the greatest honors of my career to have been chosen to work here. Looking at a trailblazing map to kind of keep the metaphor or whatever going, we're going to go through what we get to do, what does a hospitalist do, a little bit on that, how will our hospitalist team help with Pinedale's pioneering, and then some question and answer comment time. I should mention that the team is all here. We have 3 full-time hospitalists. Dr. L over there flew in, even though he hasn't, he's going to be starting in November, but he wanted to be part of this. And Dr. Curley, who's on service now. This one is self-explanatory, except that it kind of reveals something about my rather warped sense of humor. Everything I'm going to say here and what I saw as being a huge appeal to coming here was what I consider to be the foundation of autonomy of the local hospital and healthcare system. Because, of course, you know, I've worked in contexts where I have kind of a comparison and contrast. And so I wanted to like make that clear up front. You know, this beautiful edifice and you've got the pillars supporting it. And I think that's, like I said, a big part of the appeal for me. So what do we get to do? I tried to come up with what do I think captures the vision that we have in Pinedale? And I came up with this: to collaborate to provide the best quality care for the health of our community, exemplifying a system dedicated to truly meaningful patient-important outcomes. So why did I choose the term pioneering? Well, it wasn't because of this idea of reinventing the wheel, like nobody's ever gone this way before, but it's really pioneering in a relative sense because so much in healthcare has gone in a really off direction. And you could look at it as a renaissance of true healthcare. Not reinventing, but just returning to these things that I think we all know more or less intuitively are what constitute truly good health and healthcare. So looking at some words and stuff, breaking down that mission statement or whatever vision statement that I had there, we'll be looking at these things: best quality care, outcomes, collaboration, and exemplification. Excuse me, how do we define quality? Well, again, what do we say when something's high quality? It means it's done well, right? It's a degree of excellence. But in order to understand that, we have to understand what was the intended purpose. If I am doing a great job mowing the lawn, but somebody has actually wanted me to do other landscaping, then I'm skewed, and my quality for the job that I've been tasked to do is poor, right? So it requires then some further definitions, and health, patient, provider, healthcare, all of these things are going to dictate what we consider to be quality and whether or not we're fulfilling it. And so one of the big things with evidence-based medicine didactics when it was evolving in the late 80s up at McMaster University was case-based studies. And so I want to illustrate some of these definitions by looking at cases. So I'm going to take a 65-year-old patient with diabetes, cholesterol issues, hypertension, and we want to look at what constitutes meaningful health results after 6 to 12 months. So patient A says, no, I just want to do some lifestyle changes, schedule light exercise, senior yoga, things like that. Patient B says, no, I want to go for just give me the medications. And so a typical regimen of diabetes and blood pressure and lipid medications there. So these are often measured with the technical term is surrogate markers or surrogate outcomes, as surrogate as substitute. It's a concept that when properly used is essential, but it can be very misleading. And So that's beyond the scope of this talk, but just to introduce that. So A1C, lipids, blood pressure readings, these are going to be the ways that in this case they're often measured. So patient A with lifestyle changes, 25-pound weight loss, they're moving better, they have better pain control, sleep is better, stress reduced, but the numbers don't quite make it, not quite at goal for an A1C, not really at goal for a diabetic with the LDL. Systolic blood pressure could use a little improvement if we're going to go by strict guidelines. Patient B with the medications, as you see down here, oh yeah, the cursor does show up. Well, the numbers look great, right? But look at the patient. Gained a little weight, stiff, can't move as well, still a little off balance, now needing to take a sleeping pill, relational stress, and so forth. And so the question is, which one of these really constitutes meaningful health outcomes? So getting into a little bit more formal definition, this term patient-important outcomes is something that was minted, as far as I know, by the NIH and the FDA, and how we feel, how we function, and how long we live. And so I think a good operational definition of health is feeling and functioning as well as possible, as long as possible. And I think that, you don't need indoctrination or lots of training or anything. I mean, that seems to me to be a pretty gut level response. So there's that definition of health versus a number or a quote abnormality that is questionably destined to harm as defining a disease, or conversely, you're healthy if we can't find anything wrong with you. Definition of a patient, again, is this a fellow human suffering from or seeking to prevent patient-important outcomes, heart attacks, strokes, dialysis, things like that, or is it a consumer accessing a product? And obviously there's a financial aspect to medicine. I'm very keen on that and making sure that that's taken care of. But this is, as we look at what's of the essence of the definition. So again, defining by example, provider and healthcare. One of my evidence-based medicine mentors is Dr. Victor Montori. He's a Mayo Clinic endocrinologist who's done a lot of great work in this area. And several years ago, he started an organization, a nonprofit called the Patient Revolution for Kind and Compassionate Care. And I love this quote. It's on the homepage on the website. We must transform healthcare from an industrial activity into a deeply human one. And what I particularly like about Dr. Montori is, if you ever listen to him lecture, this guy is in an elite class of evidence-based medicine experts, like world class, got all the statistical tools. He doesn't probably have a lot of peers, and yet he sees that as very naturally leading to what we have here. Definition of a provider, again, a servant leader who applies an accurate understanding of physiology and pathophysiology to help patients feel and function as well as possible for as long as possible, or that same skill set in heart, focusing largely on achieving surrogate endpoints that have minimal or limited relevance to patient-important outcomes. So a word about evidence-based medicine. This next slide is from one of Dr. Guyot's talks, and there are 3 principles of EBM. The first, some evidence being more trustworthy than other evidence, so we need to know how to appraise the evidence, kind of what you would expect. Clinical care requiring best available evidence summaries for point of care, and that already gives us a sense of the direction of EBM. It's not some cold analytical academic thing. It's supposed to inform and empower, not supplant the point of care, the bedside, if you will, or the clinic. But this third one, I still remember the first time that I read this in an article that Dr. Guyot was having as this dialogue with another physician. And evidence by itself is never sufficient. It has to be applied according to the patient's values and preferences. I about fell off my chair when I read that. I think it was probably back in 2014. And it was like, wow, I mean, that's exactly what I believe. But here's the guy that, the program Up to Date hires him to instruct their senior editors. And this is what he, and not just him, but the whole, movement is saying. So I think that's very important. Now, I think, again, to illustrate an example of quality, I've like to take the example of Rita, who was the head of housekeeping in Baker City, where I was just prior to coming here. And she is a lovely, hardworking lady. And I went into the room one time with this patient. It was close to his discharge. And I saw her kneeling down on the floor, helping him put his socks on. All right. Well, this is the head of housekeeping doing that. And here's Rita. You can see her. She gave me permission to use her picture and her example. And why do I think that she is an exemplification of quality? Well, she enhanced a patient important outcome. The guy needed his socks on, feel, function, safety, things like that. But I think probably most importantly, she showed him that she cared, and she was kind of the face of the organization in that moment. She went outside her more narrowly defined role to serve the patient in an appropriate way. And in doing that, she exemplified leadership, modeling it for her staff and for others. And obviously it had an impact on me. I told admin about it and nominated her for some of the awards of this sort of stuff that they had. So this is a question not to answer, but how do we measure, but even much more importantly, how do we cultivate this kind of quality? I think that's one of the huge opportunities that we have in Pinedale. So a little bit about collaboration. I had mentioned that, and I've worked with different administrative people, boards, and so forth over the years. And just as I reflect, like, what's most helpful and what has gotten in the way, well, a huge thing is understanding each other's worlds. What does the board struggle with? What does admin struggle with? What do providers struggle with? What is housekeeping or dietary or whoever? And this idea of open dialogue, just sort of an atmosphere, can go so far to eliminating the unnecessary barriers and disjunction. I think a clear definition of terms and goals, which is why I wanted to just briefly introduce some of these ideas and definitions, not just general goals, but more specific. How do we define goals? What are outcomes? What are meaningful outcomes? What are necessary outcomes, but for insurance or whatever, but how do we frame those, that kind of thing. And I don't want to give the wrong impression. I mean, there's a place for numerical metrics, but I think that they need to be taken in their context and used as tools. I used lab values when I was in the clinic as tools to try and motivate people for the other things. So they don't have to be antithetical. What does a hospitalist do? Well, for those of you who are not familiar, the term was coined in 1996 by Dr. Robert Wachter. The focus is non-surgical management of hospitalized inpatients, and some of the conditions we would manage, I think, probably what you'd imagine: heart, diabetes, infections, lung conditions, things like that. And what are the benefits? Well, I think, again, you do a lot of something. If you're doing it right, you get good at it. You get better at it than I could have been just working in the clinic. And so higher quality of care. But that also promotes higher quality care of the outpatients because the clinic providers are better able to focus on their practices. That in turn, enhancing recruitment and retention of clinic providers, I think is key. I've seen that in various places over the years. And then, of course, serving the community by allowing patients to be cared for locally. So how will our team help with pioneering? Well, I think there's a quality of care and experience. There's a lot of experience between the various Apogee folks that are here. Dr. Klein, both as a physician and managing programs, Dr. Curley and Dr. L, a variety of hospitals taking care of a lot of patients. And I think importantly, the comparison and contrast, we've seen how it shouldn't be done in so many cases. And I know from talking to all of them, we are excited to be part of helping build how it should be done. And that came through loud and clear from the very earliest conversations I've had about Pinedale. Enthusiasm, again, that's, if nothing else, that's what I want to share for today. Dr. Klein came out for the Boots and Scrubs event. He and I have done a lot of planning in the last few months. Dr. Curley emailed me after day 2 and said, as you can see, this is the most unique and exciting opportunity I've ever had. Dr. L flew out here even before he's officially started, and a few weeks ago, he was already inquiring about logistics to help the patients. Like, there are no pharmacies open on Sunday in Pinedale. Do we have a system in place to do that? I mean, the level of engagement really struck me. So, excuse me. So creating a positive evidence-based healthcare environment, teaching, we're all engaged in teaching. We love it. And I've already started working with the nursing staff to develop kind of a supplemental curriculum based upon their interests and perceived needs and things that I've observed over the years. And then communication, collaboration, other leadership. I mean, I guess the two messages that we want to leave most of all is we think this is an incredible opportunity. This is cool. It's unique. And we want to help however we can. And we may not always know what that constitutes. But so I chose the exemplification part, even though I was going through some of the collaboration and other things earlier. I wanted to end with this because I thought it kind of coalesced everything. And I used a city on a hill metaphor. Again, because of the vision and autonomy that there is in this organization, the ability to influence just by what we do, by who we are, is national. That's not an exaggeration, and possibly even international, because we can serve as an example of how to do it right with healthcare. And I think it's just sum it up by saying this is a pioneering program that we can take to great heights, and we've already seen some really wonderful things. So with that, questions, comments, hard questions, I'll be happy to have my colleagues answer for me.
What are some of the biggest challenges you see us facing at this moment, Dr. Berger? I mean, we've been in operation just a little over a month now, and we've definitely had some roadblocks, some obstacles. But from your perspective, what are some of the biggest challenges that we still face?
The one that comes to mind is the further development of ancillary services, various therapies, respiratory therapy, PT, occupational therapy, echo, things like that. And I guess my sense was all in due time. But again, I really want to, because I know just from talking to people and looking at them and feedback I've gotten, I get the sense that you've been pushed to the limit. And so if it helps to come in and say, yeah, whatever needs to be fixed, no doubt. But this is what has been done here is amazing. And so, but yeah, that would be probably the primary thing that I would list.
Thank you.
Yeah. We had Melissa, I think, did you want to say something?
Yeah, me too. I can get through this without tears because it's pretty emotional. So I think what we're talking about here is paradigm shift. And the reason I'm in tears is because of this man.
Are they able to hear you?
I don't know if they can or not. I'll try to speak up.
You can sit down.
Oh, that's okay. I'll be better standing up. So my mom's 83. 16 days ago, we brought her into the ER, and it was her second trip to the ER in our new hospital in 2 weeks. And 11 days ago, she was released. And she had a lot of issues. She came in because she was dizzy. She was passing out. Her systolic blood pressure was, we had significant drops, like 80 to 60 point drops when she would go from sitting or lying down to standing up. She had been seeing physicians for years. 10 years ago, she was diagnosed as having kidney disease, having high blood pressure. She was on all these meds. And when I say paradigm shift, we would see a lot of different physicians. And I'm not knocking anybody because, again, paradigm shift is the way industrial medicine has been. You got 15 minutes, give her a pill, slap a Band-Aid on, next patient, right? So we get there, and Dr. Berger listened to us, asked us questions, heard what we said. He took her off of her blood pressure medicines. He changed her hydration. I mean, there were like 5 things we identified, right? Changed her hydration rate, changed her food, both the type and the frequency which she was eating. Got her on a pain management regimen that works for her. Again, changed her blood pressure medicine, kept up with her kidney labs to monitor that. So what we saw was, by the time she was released, her kidney numbers had been within what would be considered normal range for her age, as opposed to stage 4 kidney disease. So was she misdiagnosed 10 years ago? I don't know, but her numbers showed that she has improved because somebody asked questions, talked to her, paid attention, took time with her, right? Same thing with her food. The food, does she have blood sugar problem? We don't know, right? But changing the type of food she was eating, increasing some salt intake, that sort of thing, frequency, vast improvement. Got her pain management under control. So instead of chasing pain, now she was being proactive with it. Her blood pressure, wait till you hear this. He changed her blood pressure meds, got her off of 2, put her on 1. Her last dose that she has had to take was on the 17th of this month. She's not on blood pressure meds anymore because her systolic pressure, and I forget what the other one's called, but her blood pressure is now within the normal range without having to take any kind of medication whatsoever. Her kidney labs, as I said, when she was discharged, normal range for her. So her change in her quality of life, she's a brand new woman. And it's thanks to this approach, it's thanks to him talking to her, listening to her, the hospital, everybody there. I can say nothing but wonderful things. And again, I'm sorry I'm emotional, but I honestly thought she was going to have to go to a home when she was discharged and that she was on her downhill slide. Today, she was out with one of her best friends looking at the fall colors. 3 weeks ago, she couldn't have done that. And it's all because of this evidence-based medicine approach that he's talking about. So I came here today, tears and all, to say thank you. Thank you for the hospital. Yeah, we kept saying, and I don't know who's on the call, but we kept saying, thank God we're in Pinedale and not Jackson. You know, because yeah, it's just night and day, the care we got. Everybody there was so concerned about her and kind, and you could just tell top quality, top notch. And I just can't say enough nice things about the experience that we had with the hospital here. That's all I have to say. Sorry again for the tears.
And part of that was the Sharetta, the dietitian, came in as well.
Yes.
And met and helped to clarify some really misdirection that her mom had been given a number of years ago. And that was really timely. And so, you know, all these things working together, the attention that the nurses gave. And so, yeah, it was extremely gratifying.
Patient. Oh, patient.
Yeah. Any other hard questions for Dr. Klein?
I guess like I love this approach, and because I do feel like to some extent healthcare has become, you know, we've gotten so good at making medications to cure so many different things that okay, here's your, you know, here take this, and it's gotten too easy, right? And so I think you bring up such a good point that okay, maybe that makes their numbers look better, but what's their actual quality of life look like, right? So, you know, what do you see from patients? Like, are patients pretty responsive to, you know, wanting to change things? And even if it's more lifestyle changes versus here, just add another prescription for you. I assume it's probably kind of a mix of what you see and what patients are willing to do.
It varies, yeah. I mean, what I've seen most of all, I think, is that taking this kind of approach builds trust, which is quintessential to the provider-patient relationship and really the relationship of the patient with the organization. And if nothing else, I think that's the most gratifying, because even if they're wanting those things and not wanting to make the changes or whatever, it still, I think, instills that. But yeah, I feel like I'm dating myself, but anybody who's a fan of the rock group Rush, They had a song called Territories where they said the whole wide world and endless universe, keep looking through the eyeglass in reverse. And I took that flipped telescope thing and made a little didactic thing out of it or whatever and called it the telos scope, telos being the Greek word for end or goal, purpose to what, like what you were saying, sorry. And scope, of course, to watch. And I just inverting the telescope, we're looking through this through the wrong end. And so all the tools that we have, medications and whatever, have to be subservient to that end or we're screwing it up, to put it technically. So, yeah. So again, to come into a context like this where I think we feel like we actually get to practice medicine the way that our hearts and brains and everything want to, and to have a staff like we do that is, I've found them to be very engaged and wanting to learn and just soaking it up. And, you know, we spent quite a bit of, well, it was about 20 to 30 minutes one time with a guy who had just a classic aortic stenosis murmur, and we went through how to auscultate and how to describe murmurs and so forth. And the nurses afterwards said, you know, that's more than we ever learned in nursing school about that. And that's sad, but it, you know, these are the kinds of things we could do. And so I think, yeah, I'm just repeating myself, and I don't, I'm going to start foaming at the mouth saying this or something.
Well, one more question about like the transition, say, out of the hospital. So
Yeah.
from like the care that you have been providing back to say like their primary care provider.
Yeah.
How does that work? If, you know, you can start them on something, say you start them on new things. I feel like, you know, within, if their primary care provider is within our organization, that's the easier transition.
Right.
Whereas if it's outside, like, how is that?
Well, so far, I think, I mean, maybe Dr. Curley can speak to this. I think the people that I have discharged have been within the system. So
Yeah, almost exclusively, other than just some visitors to the area. But I found that Epic Chat, their providers, it's three people. It's not just the patient and me. We're all three. I've been doing that just daily with some of these patients. So, you know, you agree with this, we think, how do you follow this? And it's just really been super. Talk to Dr. Hasty.
Yeah. I think that continuity helps so much,
Always.
as opposed to the patient going back to their primary care provider and then saying, oh, well, no, you shouldn't do this. And then it's just constant.
Absolutely.
You definitely don't want that.
Well,
We've been able to do it very real time.
yeah, and we'll put in the discharge summary as well, the rationale. I like to explain this to the patient as well, and as I'm able or as appropriate, put little, you know, as we discussed, we're changing this and that. Ask your PCP about this. But I actually met with Dr. Hasty, and I'm sure this will be a work in progress, but, you know, having sat in his position of others like him, what's most helpful in a discharge summary? So he made some simple suggestions that I think have helped my discharge summaries. Hopefully he can weigh in on this, be better, but that would be the other way that primarily, you know, that we did this is why. But yeah, it was a critical question. Yeah,
Thank
you.
Anyone else have a question? Dr. Berger, thank you
Yes.
for taking the time.
My pleasure. And, you know, contact me if there's anything I can help with or whatever. I can email
Thank you.
my contact information to you. Maybe you can distribute it.
We appreciate it. And Melissa, thank you for taking the time to share your story.
You know, it's my mom.
That's really important for us to hear right now. So thank you.
Miraculous. I mean, literally.
Thank you. Thanks for sharing. Yeah, kids. But they were on.
I just wanted to say don't move the wings.
Yeah, for sure. Run. Just a few minutes. Maybe the get stuff.
Oh,
Almost time for crap.
I know. I know.
You're sick of the show, huh?
I guess so. That's okay. It's all good. There is not. Is he always complaining?
Yes. You getting comfy over there?
Yeah, I told him reclines.
With a little help, huh?
Yeah.
I love that Dr. Klein brought his cowboy.
I know.
You too.
He told me on opening day he was going to be here with his cowboy hat. And I said, you better find some boots too. He did.
Yeah, he did.
When in Rome. Are you wearing yours tomorrow?
What's that?
Your cowboy hat?
Should wear both,
What
the
about your
cowboy hat
bolo?
and the white coat.
What about your bolo?
You want a bolo or a tie? I can do the bolo.
Whichever, you just
You tell me
traditionally
which
wear
one
your
you want.
bolo.
I can be
so.
Western. I wear the bolo, I gotta wear blue jeans. No, I don't have it.
Okay, everybody good now? All right, well, welcome to our meeting. It's a regular meeting, September 24th, 2025. This is an exciting week for us. We have a lot going on, ribbon cutting tomorrow. We're thrilled, but we do have a lot of business to attend to tonight. So call the meeting to order and ask you to join us in the Pledge of Allegiance. I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you. We just had some board training by Dr. Berger about hospitalists and what they do. So we will dive into business. I will ask if there's anything that needs to be changed on the agenda for the evening. I'm not aware of anything. Bill, are you aware of anything? Last minute ads? Okay. Dawn, Lindsay, Lena, do we have any last minute ads? Okay.
No, ma'am.
Okay. I will ask for a motion to set the agenda then, please.
Madam Chair, I would move to set the agenda.
Okay, thank you, Taylor. We have a motion.
I'll second.
And a second by Ashley. Thank you. Any further comments? Okay, I'll ask for a vote then. All in favor of the motion on the table to set the agenda, please say aye.
Aye.
Any opposed? Motion carries. All right, first item is consent agenda. We have several reviews for, oh no, that was last week. I'm getting behind here. We have provider enrollment job description. Tonight is all.
Madam Chair,
Easy consent agenda, sorry.
I would move to approve the consent agenda.
Okay,
Provider enrollment and payer compliance specialist.
have a motion
I'll second.
and a second by Kendall. Thank you. Any comments? All in favor of the motion to approve the consent agenda, please say aye.
Aye.
Any opposed? Okay, motion carries. We then have meeting minutes from multiple meetings, August 27th, September 3rd, September 10th, September 17th, and then we have executive session meeting minutes as well that were emailed to the board today. Just going to pull up those dates unless you know those off the top of your head, Kenda.
Yeah, the 27th, the 3rd, the 10th, and then the 19th.
We didn't have executive on the 17th.
Okay. Thank you. So did everyone have an opportunity to review those minutes? I know it's a lot for us right now. Any concerns or questions?
I would make a motion to approve the meeting minutes from August 27th, September 3rd, September 10th, including executive session minutes.
Okay, thank you, Ashley. We have a motion.
Madam Chair, I'll second.
A second. Thank you, Taylor. Any comments, questions? Okay. All in favor of the motion to approve the minutes, meeting minutes as laid out, please say aye.
Aye.
Any opposed? Okay, motion carries. That brings us to public comment. Does anyone present have public comments they would like to share with us? Just had a pretty nice one. That's good to hear. Nobody? Okay, we will move on then. Next item on the agenda is committee reports, and we kind of have a limited building committee report tonight, just based on the fact that we have not had an owner's rep for the month of September, for most of the month. He has been out. So Lena is going to just kind of give us a quick rundown of the 10,000 foot view at the moment, and we'll kind of run through where things are at. So Lena, I'll give you the opportunity.
You bet. Good evening, everyone. Well, the construction project is getting close. We're getting close to wrapping it all up, which is just music to my ears. I'm sure it is to you guys as well. Just got a report today that our famous ozonator for the laundry room is actually going to be delivered on Saturday. So very appreciative of Layton that they got all of the infrastructure done and ready for that. And that ozonator will be installed, I think on Monday and Tuesday. It's a 1 to 2 day install. So we've been waiting for that for quite some time. So really excited to get that done. Things are wrapping up in the long-term care side. They're getting all of the paint, touch-up paint done. Doors are done. The door alarms are done. There's just a couple of little things that we need to address, especially after Dawn and the residents move in and are living in the building a little bit longer. Then we'll know like what we need to tweak and what we need to change. We do know that we need to add a few more pieces of equipment for nurse call, but other than that, we're getting really close and it's looking really good.
Thanks, Lena.
Yeah, I'm happy to answer any specific questions.
Is move-in still the same date, the 30th? Is that right?
Well, so from a construction standpoint, it can be, but I'll let Dawn address the bigger picture.
Okay. And I guess just one more question. Is Damon done or he's just been gone? Or?
Damon will be serving in a limited capacity moving forward.
Okay.
Yes, but he has been absent most of this month, so we don't have numbers. I can give you some round numbers if you need them to know where we're at, but we won't have a report until hopefully next month. We'll get an updated report. But we are closing in on last change orders and things. We're hopeful. I'll let Nathan speak too, but we're hopeful to be finished with change orders a couple of weeks ago, but we're kind of running into a few more things that be finished. So,
and there was one more budget reconciliation that was going to happen. Is that after all the change orders?
yes.
Okay.
Correct. Okay. Yes. So, Nathan, do you want to add anything to construction?
No, we have, I'd say about 20 other change orders that have sort of just been in the process with the USDA. A handful of them that they've just received recently. Like Tony said, for things that have popped up, just adding phone devices, whatever the case may be. Got 2 or 3 things that we're working on right now that'll really wrap up that group of things. 2 change orders that we actually just got pricing back today. It'll go into the USDA for approval pretty quick, and then I'm working on a few internal change orders with subs. Things that move from one to the other. Back charges, repairs. Stuff like that. And then we've got the final budget reconciliation. GCs and remaining money in the budget, stuff like that. Okay. As far as the building side, Lena pretty much covered it. I actually just finished washing up a little bit ago. We finished all the paint touch up and little things that were out there for long-term care, so we're good to go for tomorrow. Don's list is 100% checked off. We've got a few things that we'll address down the road. Talking about that as far as moving ready.
Did receive the second certificate of substantial completion today. I think the final one is in my inbox right now. So that's a big step. Good things happening. Questions from the group? Okay. All right. Thanks, Nathan. Thanks, Lena. If no further questions, we will move on. And the next item on the agenda is Sublette County Health Foundation. So I'll turn the time over to Carrie.
I think should use or
You can use any.
okay, just to be respectful. Hi. For the first time in the history of the foundation, we did not have a quorum. So nothing happened the last meeting, but it was fine. We did discuss informally what's next, because when the foundation started in 2022, it was just to fill the gaps in the value engineering. So get the radiology equipment, get the MRI, get the landscaping, get, all the things. And so we had one purpose only, and now we've taken a breath, right? We're hitting the end of that. So Greg had suggested starting a formal process where the CEO comes to the foundation with requests, and the CEO, as part of the budget, I think sets a CapEx budget. And so they could work that in and then give the foundation like a 2-year plan or things like that. We kind of continue that conversation with Bill and figuring out where that goes. But then I think we want to start to look at how we set that process. Does the CEO come to you and then you all make the request to the foundation board and what that looks like? But how to set priorities going forward, because it's not one mission anymore. Now we have the old Marbleton Clinic, we have the old Sublette Center Medical Wing, we have the surgery suite, we have, all these sorts of things that we could tackle. So, yeah, we talked about that informally, but we're just at the tip of the conversation. But I think it's a process that we're going to nail down, if that makes sense. The sanctuary is, I think, the last piece on our plate, and Sharon Ziegler and Nancy Stevens are still working on the structure for the stained glass. So, and then the employee break area, the board just voted today, I think, right, on an $11,000 bid from Scott Cheney to finish that break area. So that should be the last piece for us. We should be done. YO Gives, we made $31,000, which was fantastic. Boots and Scrubs was great. Jared gave an amazing concert. I hear it was a really fun event. I was sorry to miss it. We made about $5,000, which is less than past years, but we had less sponsors. And we had switched to September because we were told that August is so busy, but it turns out September is also busy. So, but we learned a valuable lesson. So, yes, so talking going forward, we might go back to August, but the food was amazing, and kudos to Sharon for all the hard work, because she really pulled off a great event. So Foundation 23 goes until the end of this week. We currently have about $5,000 in donations. I think we're just seeing a lot of donor just breath. I wouldn't even say fatigue. I would just say everybody took a breath, right? It's we got through a momentous occasion, and now we'll just take a pause, and then we will re-rally the troops. But the good news is you have a ton of your donors flying in for the ceremony tomorrow. So the airport's going to be quite busy. The Hewishes are coming. Mr. Joe Ricketts, Diana Archuleta is bringing 7 people, her grandsons, and yeah, it'll be really fun. Mark Ridley's flying in from Idaho, so yeah, should be great. Talking about tomorrow, you guys know it's Harriet Hageman is coming, Senator Barrasso, and the USDA Tyler Harrison will speak, and Governor Mark Gordon. So we will have welcoming remarks from Tanya, and then we'll pass the mic to Tyler with the USDA. Then they rank the elected officials in order of how long they've been in office. So Harriet is the junior representative. So and Hageman will speak, and then Governor Gordon, and then Senator Barrasso. And both of their offices were very polite about the order because they're kind of equal. And then he's executive branch, and they were like, it's not a big deal. So we're going to finish with Barrasso because he's a doc, and that's really fun. So all your VIP donors will be there. And then after the speeches, everyone wants in on the gold ribbon shot. All their PR teams were like, this is what we want. So I imagine it will be the large scissors, and we have between the two pillars, we'll have that gold ribbon. So you 5 will be there, and then Barrasso, the governor, Secretary of State Chuck Gray, who's on the slib board, Auditor Racina's on the slib board, and then Harriet Hageman. So you'll have 3 slib board members, 2 of your DC contingent, and you 5. Scissors, smile, chop. That'll be the moment. And then light refreshments inside the lobby. Lindsay's had her dietary team making, they were baking cookies today and plating cheese. I saw lots of little cheese. So it's modest. And then we're going to have employees stationed throughout the facility to like block off patient areas. So like on that ED hallway, you can be in the lobby, you can look down that hallway, but we'll have a person there that has a script that says, this is our 4-bed emergency department. We've added this, you can go no further. So obviously no contact with patients. We had talked briefly about trying to see inpatient rooms, and it's looking like that's going to be difficult because we're full. So Lane and Bill are both nodding. It's a good problem to have. So
really good problem.
Yep.
To have for the patient.
Yes, exactly. Yeah, not that you want to see anyone sick, but it really is. So we had thought maybe we could have the patients at the end of the hall and they could sneak in and see patient room number 1, but we're just going to do away with that. So we'll have someone at that say that, you can go no further. This is the ED, but if you take a left here, there's the Heritage Home. And then the Heritage Home, we're being very respectful of the final clean. And so it's a very small pathway. I worked this out with Taylor too, from the lobby of the Heritage Home down Main Street, and then they can see one resident room. And back. And then Don, we thought we would just flip the resident tags backwards so there's no HIPAA information out. And
Oh, that's fun.
yeah, there we go. We thought about
Patient tags are up.
yes, but they have room.
We spent this afternoon dusting all the rooms and getting all the beds made. So if
Oh,
somebody
wonderful.
wanders, they're ready.
No, we want no wandering because we don't put any pressure on Tyler's crew. Absolutely. So it is going to be a very tight ship. Like that's all you get to see. No memory care. It's a secure unit. So that sort of thing. Any questions about tomorrow? Anything?
Who's giving the tours? How are we setting up?
Well, I imagine you guys will give, I mean, your VIP, like, I imagine you want to give Barrasso a tour or Governor Gordon, or I think that's going to be, I know Hot Springs Health reached out to you guys because you were at the Health Tech Conference. So maybe you guys give the Hot Springs Health.
Oh, they're. Oh,
So that level of guests will be that, but otherwise it's just going to be people with scripts that are strategically sprinkled throughout the entire facility. And so they will be able to say, we recently added MRI, mammo, and DEXA, and it's a radiology employee that's going to be doing that, but they will just stand outside the imaging door and say, you can't go any further, it's patient care. But this is the services we've added. Thank you to the Archulettas for funding the MRI, that sort of thing.
Okay.
So
there's not necessarily a
leave every
formal,
10
like,
minutes.
yeah, we're taking.
Take a
Canada
flag.
today.
Yes, that seems like people love to chat in this county, and I
Yeah.
just think it's going to be. So yeah, we're going to have people around that say, hey, if you want to wander this way, you can see the Heritage Home if you want to.
It's
Yeah.
more so like a guided open house tour, but
Okay.
like very limited area.
Very-
So that
Yeah.
way they're not wandering. They're kind of in a secure area that
Yeah.
they can still see it, come and go. But it's not bogging everyone down to personally walk them to.
Sure.
Yeah.
Sure.
And like past the CEO's office, there's that hallway where you can turn into the Heritage Home lobby. We have a person there that says, go no further. So the east wing of the Heritage Home should be completely off limits, untouched, perfectly clean, but they can go down Main Street and just walk that center aisle and see. Yeah. It seemed a lot to teach people the entire script, and it seemed a lot to
Yeah.
gather people because people don't they start chatting, right? And
Yeah.
they want to visit. So
Yeah. Yeah.
I know.
Start off, but keep it limited.
Yeah. Absolutely.
And then kind of like a flow.
Yeah. Be able to see.
I think so.
I suspect there will be people who want to see the memory care wing as well. So I don't know I don't know. I guess we can just kind of see how tomorrow goes.
That's
but
up to you. I mean, if you want me
maybe
to,
just
yeah. If,
dignitaries and
Hmm?
we'll see what the other numbers are like. Did you have
That's
something to
easy.
say? Dawn?
Bob's let us in, so we'll just, I think it's wise. It's a beautiful space.
Yeah.
beautiful.
Yeah, I suspect there will be a few who ask
And we don't have patients
specifically.
up there right now, so just go up in the morning, flip all the tags around and that'll be fine. I'd be happy to help with that.
Okay, yeah. If you're willing, we wanted to put memory care on. We just wanted to be respectful of the final clean. So if you're
Yeah.
good with that.
Yeah,
Okay.
and that was my biggest concern, was just the final clean.
Yes, I
I
know.
see those bills and
Yep.
and I'm nervous, you know, that
you
the
wanna keep the
residents
building
have a
perfect.
beautiful, clean, spotless facility to move into. So those were my biggest concerns.
And I'll be
but-
up there, like, I'll be the.
Yeah, I think as
person up
long
there.
as-
This is neighborhood concept, whatever, so that'll be easy.
Yeah,
Oh,
as long as we
perfect.
don't have people just wandering, I think we'll be okay.
I think so. Yeah.
So, with some efforts.
Good. Yeah.
Everybody
I'm
ready
excited
to
for
get some
tomorrow.
doors?
Yeah, you exactly. You're all ready to talk about your amazing project. It's quite a moment. So
Who's gonna get lost is what I.
That's why we
have
it very
limited. Yes, very
That's
limited. Yeah. No wonder.
That's my other concern, you know, it's kind of easy to get twisted and turned around.
Jeremy's gonna be
Yeah.
here too. He said everybody that's doing the chaperoning can best.
Memories.
We want to be past our
I
hats.
never want to wear.
I know, right? Ever again. Oh, but in that vein, we are having golf. We got 3 golf carts from the county, and Tyler's bringing his golf cart, so people can park that north town lot above the north of the Heritage Home. We'll golf cart and bring them to the ceremony, and then we can use the museum and the Mountain Man parking lot. They gave us permission there too, so. So we'll have golf carts running from the museum. Yeah, because parking, I mean, we're going to see how many people we can cram on this hill. It's going to be something. And the sheriff's office is looped in. Senator Nebraska security detail came. So I think security wise, we're set. So, yeah. Okay. Any questions, let me know. Thank you guys.
Thank you, Carrie. See you tomorrow. Okay. That is the end of our committee reports. So we will move into leadership reports and hear from Lindsay first on operations.
Okay, that was a good talk about the future. If you'll allow, I would like to just take a moment of reflection. So normally I have 1 or 2 leaders come up here and give their report. So the 5 of you can get to know the ones behind the scenes, creating the vision in place for so long. September 16th, we got our survey results back from CIHQ and passed. And then I believe today we got our provisional license from the state. So to extend that to the end of the year. So very exciting. Tomorrow, we're going to focus on this wonderful guest list and all these great people that are coming to celebrate with us. I think if you'll allow, I'd like to spend some time on reflection on the group of leaders that have gotten us here so far. And I loved what Dr. Berger said about how amazing our team is, how amazing this venture is that we've accomplished. And I just want to take a moment of that. So I do need to read this so I don't forget anybody. So I spent the last couple of weeks in a mode of reflection, walking the halls every day of this beautiful building, listening to the directors gathered around the table at our weekly meeting, collaborating with one another as I watch them, knowing their stories, knowing their journey, and watching them own the space they are in. I swell with pride. My healthcare career has put me in front of many different teams. Like I always tell you, tomorrow we welcome an incredible guest list of people to celebrate the district. Tonight, I would like to recognize the directors. This is for them. So we can do it. A phrase soaked into the table as your directors gather around. I'll come to them and say, guys, we have a problem. We need to figure out our options on how to fix it. Their response, we can do it. Money is tight. This job needs to be done. Should we look at an outside company? Their response, we can do it. Guys, there are 900 policies we need to build out. This company wants to charge us $1 million, but they'll do it for us. No, we got it. We can do it. Kathy Donaldson and Kimberly Irvin have grinded over conditions of participation, regulations, protocols, competencies, compliance, contract management, and developed a platform where all policies could rest. Brett Kirshner has grinded over filling a hospital and long-term care facility with phones, workstations, low voltage, internet, maybe those are the same things, Ocean integration, a new email system, and dealing with a COO whose computer monitor just needs to be turned on. Durain Clark grinds through revenue cycle as our sole coder, training of new billers, the build of a new system, making sure the systems talk to one another. Christy Bartlett led the charge of a new EMR, built an entire quality department that encompasses health information management, grievance and event reporting system, QAPI, infection prevention, employee health, HealthStream, and FinThrive, all while never shying away from picking up a nursing shift on the floor. Bonnie Hunter grinded through the need to double her staff, build registration and a new system, training around the clock while always up for covering a spot for her team, pushing through issue after issue, exploring new ways to succeed. She works 12 hours a day, whatever it takes to make sure the shifts are covered. Michelle Stouthammer grinded through implementation of a new financial platform, sorting through construction invoices, preparing for audits, delivering budgets, reports, safeguarding every friggin' penny. Tyler Bell, his first job in healthcare, developed our new facilities department, recruited a full staff of maintenance, laundry, central supply, housekeeping, environmental care, co-spearheaded the build of emergency preparedness and incident command center, all in shorts. Kayla Bowers grinded in the expansion of the imaging department, recruiting the unrecruitable roles needed for MRI, CT, X-ray, ultrasound, DEXA, mammo, all while working with physicists, radiologists, ACR needs, and PACS. You can also run into her in the middle of the night covering call. Carrie DeWitt pumped out press release after press release, developed forums to keep the community engaged and apprised of the latest updates, leads the foundation in raising millions of dollars, built a robust marketing campaign, created our patient guide, writes grant after grant, encourages staff to continue education, keeps her head up to keep spreading the good word while her colleagues' noses continue to stay down and grind. Sharetta Walters sliding in at the buzzer, saving the day and building out the once fragile dietary department, advocating for her new staff, recruitment of more staff, getting us to pass our kitchen inspection, learning a new point of sale system, building a new menu, oversight of new equipment, chasing down vendors, working with dietitians, getting staff certified, studying for her CDM, all in a hairnet. BJ Mary came into EMS and spackled the cracks of the foundation of his department, sustaining the current crew, worked like mad to fill every open spot, put the EMS department on the straight and narrow, developed reports and assessments aligned with outside organizations to make EMS's services robust, gained the trust of his great team, co-spearheaded emergency preparedness and incident command center, fights for grants so the community that deserves the best is getting the best, and in his spare time, educates on all aspects of health for first responders, and he's working on his doctorate. Vicki Marshall, grinding through training staff, recruiting staff, keeping up to date on all competencies, poring over different staffing grids, always fighting for her team. Then, when faced with the unimaginable, her team expressed their loyalty and love for her by setting up the ED and inpatient departments on their own. Parts of staff held back to cover the clinic so that their colleagues could work round the clock to make sure the hospital was ready to serve the community. Susie Hopkins started and hasn't stopped, building out our new pharmacy department, new equipment, DEA enrollment, CSAUS, NCPDP, 222s, PICSIS, policy development. I know what almost all those mean. Working with her peers, sometimes a little blurry-eyed when she is called in the middle of the night after a long day building the department. Sharon Roosh only knows how to grind and is through the transition to high complexity lab. Blood bank build, staff recruitment, new CLIAs and COLAs, new equipment, also taking on the role of HR director, writing all job descriptions, helping to revamp the HR department, organizing our benefits package, digitizing our old paper employee files, wage scales, credentialing, privileging, insurance enrollment, personnel needs, job fairs, new evaluation process, onboarding orientation. A final important shout out goes to our perfect Jan Maxfield. Little did Jan know when she signed up for this position how crucial of a piece she would play, or how many board meetings we would actually have. Can't even look at her right now. I honestly can't believe her fingers still work. From the top of the org chart down, she keeps us all organized and as efficient as will allow her. Her voice and discernment are strong, and she is a confidant to all. Our new interim CNO, Lane Harrington, has fit in perfectly and has hit the ground running. We owe her a huge debt of gratitude and has come in teaching us all so much, taking us all to the next level, all in such gracious manner. We're excited for this next chapter and promise to not take our foot off the gas. We welcome Bill Patton to the organization and are hopeful for his wise counsel, elevating our current path to prepare us for the long future ahead. So thank you for allowing me to do that. It's just a wonderful team. And it's Vicky's fault I'm crying a little bit right now. So, but it's a wonderful team. Just want to promise to the board and to the community, we're going to keep going and keep striving. But just wanted to take a moment of reflection. So, okay.
This is a good time to reflect.
Yeah. So, do you have any questions about your leadership reports? All right. Thank you.
Dr. Burnett?
Well, good evening, Madam Chair and Board. My report is very short and limited. The credentialing bylaws and MEC have been doing their due diligence to work through the exhaustive and extensive credentialing files. We've made good progress, and kudos to them for their hard work and efforts. Other than that, we have no position concerns or problems that I can report to you. All is well in the House. Any questions?
Thank you.
Okay,
Thanks, Doc.
thank you.
All right. Dawn?
I should also be pretty quick. Did you happen to get it up on Dylan?
I did.
Oh my gosh. So kudos to you. This was like a last minute thing for me because, well, we have a COVID outbreak down at the nursing home. So, we'll deal with that in a minute, but I calculated how many meetings you and I have had together, and it is 170. 170. And for the most part, we have talked about either merging with the hospital district or not. And it's been like this 10-year journey for Kenda and I. And so this is the last meeting that we're going to have as Sublette Center, which makes me a little bit, but the future is so bright. And I have always been a proponent of what's next. You know, I think all of our teams are that way. In fact, Bill had revived the senior leadership team. So for the first time in a while, we met together in formality. And one of the things that came up in that agenda is what's next? What are we doing for strategic initiatives and making sure that tomorrow isn't the end, but the beginning of a really cool journey that we all get to do. So I'm just excited for the opportunity from a nursing home standpoint to really do continuity of care, neighborhood concept. It's a big gift that's really going to impact how we care for this community. So thank you, 170 and counting. That is so much, but okay. Okay, so let's get down to business. Staffing update. We do still have an increase, dependency on travel staff. And actually that's increased. We've talked about that with the neighborhood concept. That staffing model is a little bit different. And unfortunately, where we're at right now, we thought we'd already be in the building. So I'm a bit overstaffed right now, but we are using time wisely to pack and, like I said, send people up there to make beds today so that when we do move, we're going to be ready to go. I do have 3 CNAs on travel staff, and we are actually thinking about, well, not thinking, we'll be onboarding another 3 in September. So our first order of business is to reduce our dependency on travel staff. We've had this conversation before. The next CNA class runs in October. Yes, and so we'll be sharing some of that stuff. One of the great things about the CNA class is we'll be using it for both the nursing home side and the hospital side, which is really exciting because typically you just think of that as long-term care, here you go. But now we're offering, especially for this younger crew, options. Because believe it or not, not everyone really wants to work in a nursing home. I know that's shocking. So the fact that we can offer, you know, one of the things we talk about a lot at the state level is the outflow of people. And I think we even see that in our own community. We educate people and they leave the state. In fact, it's up to 70%. We learned that at the Leading Age Conference a couple weeks ago, speaking with the president of University of Wyoming, said they are still struggling with educating our students who then out-migrate. And I think we see that in our own community. So the more we can offer avenues for employment here is just really a blessing for this whole community. So again, that's really to the teams that are working, but also to your leadership. Labor hours, we're not going to talk about that till October.
I'm a little scared about that. You know, I'm a labor hours girl, so it's going to be high. Our current census for the month of August was 36, up from 35.4 in July, and your breakdown is right there. Moving on to quality, like I said, we are in COVID outbreak. So I want to call your attention to page number 2 of your handout or your scroll. We put it on Facebook this particular week, you know, hey, we're in outbreak. And we did get some, you know, how do I want to say this? Maybe not nice feedback about fear mongering, etc. You know, and so I do need to draw your attention to the fact that the nursing home is still required to do 2 levels of advisement. We have to advise the community because they're going to come in and out and visit, and we have to advise individual team people. So basically, on a COVID outbreak, our first priority is to keep residents safe. So we are still encouraging residents who are positive to stay in the rooms. It is almost 80% of our population, which is why it's adjusting our move date. 1 or 2 people you can work around, but most of them, it's not kind to move people very fast when they're not feeling well. So if residents want to leave their rooms, we do encourage to wear a mask or social distancing. There are choices still involved. You don't have to wear a mask. You can choose to social distance. But if I'm positive with COVID, I can't sit right next to Jameson. We still try to encourage social distancing because our second priority is to prevent the spread, and our measures for doing that are right there. What I just talked to you about. Meals are served on disposable dishes for the most part. The front office is open, but the door is shut. And we do encourage for the first time for all of our offices to be closed just to help prevent spread. And we do try to limit gatherings that can't accommodate social distancing. We will be front and present on Friday for that homecoming parade because that is the biggest thing we do. But everyone's going to be spread out. It'll be cute. The third priority is to monitor. And because we're in a small facility, we know who has it, who doesn't. We don't have 200 beds. You know, we got 40 people kicking around there. We know what's going on with them. We do have to do serial testing still. So every 3 to 5 days, we do have to test. And so the news right now is just getting worse and worse, right? But we know it's just the nature of illness. We won't be having the same conversation 7 to 10 days from now. You will be notified, residents will be notified with results ASAP. Our staff can work when they are positive. It is okay if they do not have symptoms and they wear a mask. So these are some of the things you hear people mentioning in the community, and I want you to be aware that we are on top of it. We're not fear mongering. We are following CDC guidelines. Lastly, we have to report. So we do have to report to the community. I'm not entirely sure I will make the same decision to post on Facebook again. We might just put it on the website because that's okay. We have to, so maybe we won't do that. We do report to individual families. It's done either via email. If you have not given us your email, we make phone calls. Again, we have 40 patients. And then we do our state and federal reporting, and then we follow internally at QAPI. So there is a whole process, and I felt like it's important that you know what the process is, especially since, you know, it's still a thing. It's not always going to be a thing, but it's certainly handled differently than it was in 2020. So that's it on that. Miscellaneous. We divvied up rooms this week, and I said, you know, I've talked about this before. I want to be full when we move up, but I want to still have some product to be able to offer the community. And that goal was met because every room is spoken for. So when you see all the turned around signs, like there, we have some beds, because remember we have those semi-private rooms, and I do have one memory care space left. But for the most part, we plan on moving in with just one. Remember, I was like, I think we'll move up with 4. No, we'll be moving up with roughly 8, assuming nobody changes their mind between today and when we plan on moving. I won't have a real date on that until tomorrow. I have a call with the state on that. Typically speaking, you want to wait and move everyone 10 days after your last positive, or you can do 72 hours past your last documented symptoms. I think we're going to go with the 10 days because we are moving 40 people. So I'm going to be like, hey, we're doing this in 4 days. That doesn't sound like a very good idea. But I might change my mind on that depending on what the state says tomorrow. And then lastly, we've been attending some OHLS and Medicaid meetings regarding the big, beautiful bill. You've all heard about that. And the state is preparing to make their application. So this will have implications on the long-term care side and the hospital side, which I'm sure Bill's going to touch on that. So that's been taking up a bit of time. So part of the parameters that the state is kicking around right now is long-term and sustainable. So if you guys have a specific idea as leaders in healthcare, you know, hey, our community could use more nurse training, whatever it is, feel free to email me if it's long-term care related, and I will bring that forth in our meetings, because it's going to be a while, but they're nice enough to be soliciting actual input. And that is where being part of the state of Wyoming is so amazing. Like, look at who's coming tomorrow. People care about us in our small town, and they're listening to what we have to say. So I would encourage you, if you're thinking about, you know, long-term sustainable plan, I wish we could have this, I wish we could have that. Might not be practical, but I'm happy to bring it forward because people are listening to what this community has to say. So that's it for me. Thank you.
Dawn.
Thank you.
It's good, really good information. I just realized as we were going through here that we don't have a spot on the agenda for Lane. And Lane, I don't want to put you on the spot, but do you have anything that you'd like to share with us tonight as part of your
Well,
report?
the only thing I'd like to say is I am so happy to be here. Great team. We're working fast and furious to get through to our next survey. I'm excited about that. We've done a lot of things on our corrective action plan to prepare for that. And Vicki and the whole nursing team has just been phenomenal to work with. So,
Very good.
so hopefully I'll have a spot next time.
Absolutely.
And I'll hopefully be able to bring you quality data from our QAPI team and go through just a short education for the acronyms that we use in healthcare, HAIs, HACs, you know, all those hospital-acquired conditions and infections. And then what I'm used to seeing as a report card or a scorecard, if you will, from the nursing and hospital side to the board. So we'll establish whatever those parameters are and what you all would like to be a part of and see.
Thank you.
Mhm.
And I apologize for missing you today.
That's okay.
We'll make sure you're on the next one.
Thank you.
All right. Anyone have any questions for Lane before we move on? Okay, next item on the agenda is a health tech update by Dom. There's Dom. Hi, Dom.
Hi, good evening, good afternoon, everybody. How are you all?
Good. How are you?
Good, thank you. Nice to see all of you again. I just wanted to start off with, just to piggyback off what Dawn was talking about in her update a few minutes ago. As I'm sure you probably all know, it's really up to each state as to how they distribute the funds that they get from the rural health program. So it is really, really vitally important. You know, Dawn was saying, you know, if you have ideas, please pass on those ideas. But at the same time, it's really, really important that you try and find out from the state what their pitch actually is. You know, you need to know what they're pitching for. Because at the end of the day, it's going to be up to them as to how they decide to split up the funds that they receive. So I just think that it's really, really important that somebody, either on the board or in the leadership team, and I can follow this up with Tanya and with Bill, that somebody's identified. I know that Scott Elwin, the CEO at Hot Springs, in the next week or two is actually going to be attending a State of Wyoming meeting specifically with regards to the Rural Transformation Fund. So I'm going to try and I will get that information and I will pass it on to Tanya and to Bill. It would be great if somebody from Sublette could also attend that meeting. The first deadline for the application by each state is the 5th of November, so it's just around the corner. So the sooner we can get on top of that, the better. Then to move on to a few other things. The first thing is just to let everybody know, you know, we had a really successful conference, and it was really, really nice to have Taylor and Ashley attend the conference with us. Thank you to both of you for being there. I can tell you that I can tell the board and the rest of the trustees that both Taylor and Ashley represented you extremely well. I tried to make as many introductions as I could to both of them with other board members and CEOs and that sort of thing. And hopefully I did that successfully with at least a few people. I know that they spent some time with the Hot Springs leadership team and one of the Hot Springs board members. And I hope both both Ashley and Taylor got something out of the conference that was very worthwhile. I will be distributing the decks and then the information from the conference that'll come through our marketing director. So you'll be seeing that pretty soon. A few other things that I wanted to mention in terms of an update. Derek, our chairman, is going to be setting up the kickoff meeting with Alreen, Margaret, and Patrick on our team. With Ocean, hopefully that'll be next week so we can get the data feeds going. We had a little bit of a delay there for kind of a ridiculous reason, but we were trying to find out if they had actually been paid their first 50% or not. So we had a little bit of a hiccup there, but we'll get it going very fast. Derek and Alreen move very quickly, so I think we'll get on top of that in the very near future. Then 2 other meetings which are going to kick off next week on a regular basis. The one meeting will be a weekly revenue cycle meeting, which will be with Margaret and Alreen, and still to be determined from the hospital side. I got to speak to Bill as to who else is going to be in the meeting within the revenue cycle department. And then starting next week, we will start with our cash call meeting, which will be myself, Bill, and Patrick, and that'll be a weekly meeting as well. So by the time the next board meeting comes around, the next one comes around, we should have a lot better data to share with the board than what we currently have. And I think things will be running a lot more smoothly from a reporting point of view, specifically to financials as well as daily tracking of what's going on within the hospital in terms of trends. And then the last thing I really wanted to just say was, it was really nice to see and to hear that lady who came into the top of the board meeting today talk about her mom and her kidney problems and the experience and, the positive turnaround that, both her mom and her had experienced. And I just wanted to say to everybody, opening a hospital is really, really hard. It's no easy task. And, just listening to somebody's, say what she said is really, that's the proof of the pudding. That's why you're all putting in all this hard work. And obviously, there are roadblocks and there's speed bumps and that kind of thing. But I think that, the hospital has done extremely well in a very, very short space of time. The deadlines have been horrendous and very, very tight. And we move on to the next deadline and we'll get the next deadline. We'll meet that deadline. We'll make sure of that. But it was just so nice to see, because that at the end of the day, that's exactly why you're doing what you're doing. So I just thought I'd mention that. And I think that's my update for tonight. Thank you, Tanya.
Thank you, Dom. Does anyone have any questions for Dom? No, thank you.
Thank you.
Okay. Thank you, Dom.
My pleasure.
All right, finance report is the next item on our agenda. So Bill and Kenda, you're up. You've been just sitting here so quietly, listening.
So I would say that our finance report is a work in progress.
It's understandable.
So, and this is a report for August. August numbers were not positive. And while I wouldn't go so far as to say that I don't believe them, there are certain elements that either I don't understand completely or I'm a bit skeptical of. So somewhere in that area. So an example would be, so you can pull up the financials, right? You can see them. So if you look at the
So I'm on page 2 of 15. And I have the ordinary income expenses, that section. You see where I'm at? Okay, so line item 3100 revenue. That $919,000 against a budget of 2.5 million, basically. That seems to be a catch-all account that a number of different service lines are being lumped into. And I want to have those broken out. So like the clinics, I want to show the Pinedale Clinic is a line, Marbleton Clinic is a line, for example. But it seems as if some of that is rolled together. And then another thing that I just don't know the answer to yet, we show $500,000 in revenue for the emergency department, but no budget. And so I just need to understand where all of this is coming from. DZA was on the call at Finance Committee, and I need to spend time with them because I'm not sure exactly what it is that they're doing. So that's one of the things to evaluate. Are we getting value for the money we're spending? And I'm not meaning in any way to criticize them. I just don't know at this point. So if you do the adjustments to income, we ended up with about $1.2 million in revenue, right? So 2.5 total income, and then you do the adjustments. And so total cost of sales, that line, about 1.2 million. The adjustments kill us. Every hospital I've ever been at, adjustments just beat the living daylights out of us. So then you add expenses. So I really focus on the first three: wages, taxes, benefits, and I compare them to budget. And those aren't too bad. Actually, the benefits were much lower than the budget. Taxes were lower than budget. Salaries were really close to budget. So in that area, that was good. I also look real hard at purchase services. Let me find it. So one is contract labor, 7,000 on the list. And you can see that was real close to budget. And then service agreements much higher than budget. And I'm guessing that what that was that when the budget was built, we didn't know all the service agreements we would need. So I would chalk that up to timing. So then I go all the way down to total expenses, 2.9 million. So this is the next page, page 3, 2.9 million against a budget of 3.1 million. So at first blush, you say that's great, 178,000 below budget. But when you compare that to what our revenue was, about 1.2 million, have a loss of 1.6 million. And so I think of that as from operations. And then you have the other stuff that isn't operating money that helps us. But from an operations perspective, we really need to focus on that line, the net ordinary income. And then the other stuff. So philosophically, I'm of the opinion that mill levy should be used for capital expenses and construction. Now, I understand right now we have to use it for operations. Long term, I would strongly encourage you, we need to be at a place where that's not the case. Because it's so much easier to report to the community how we use their tax support when it's very tangible things. So right now we need that, and thank God we have it. But long term, I'd like to see us in a position, maybe we don't use it all, but at least we can focus a significant part of the mill levy money for capital equipment and construction. And so as we work with the foundation and develop the funding plan for a capital budget, that's part of the way that I'd want to balance that. Are we going to be able to fund any of it on our own? What can we fund from the mill levy? And then what do we need to ask the foundation? So sort of three legs of a stool. So you add in all of those extra things and you end up with a loss of 613,000. Now, in the finance committee, I asked DZA the question of what our average loss has been over the last 12 to 18 months. And the number that they gave me was closer to $800,000, right? So this month was better than that average, but even at this being better, long-term, that's not sustainable. And so we're gonna have to look long and hard operationally. And it's a two-part thing. So I had a conversation with Dom and Patrick. I don't believe in just looking at the expense side. We have to look at the revenue side as well. And so today at our first senior leadership team meeting, Dr. Burnett, we were talking about how do we work with the medical staff to grow volumes? Because in many respects, at least for that line of the business, that's where our revenue starts, is in the clinics. I mean, I know the ED, not necessarily, but I would argue that the more people you have coming to your clinic, the more people you're going to have coming to your ED because they're not so inclined to go out of town, right? And I understand that in small communities, rural Wyoming, driving an hour and a half is no big deal. Now, I would argue in the middle of the night when you have a heart attack, it's a pretty big deal. But for primary care, when I was in Powell, we actually, as part of the facility master plan, we did a study on what does it cost us every time a patient leaves our community to get care in Billings. And what we found was we would lose on average $250, $300 a patient. But the surprising piece was the community lost almost $1,000 in retail business. So when care leaves the community, it doesn't just hurt us, it hurts the community. And so I would argue that part of our mission is to be a responsible part of the engine, the economic engine within the community. And so the more people we retain, the more we support the primary business structure within the community. Does that make sense?
Absolutely.
Yeah. So as I look at, and now I talk too long. As we look at different options, I'm not going to just focus on expenses. I want to focus equally as much on revenue. Because I think that for the employees, if all we're doing is talking about cutting, especially when we just opened a hospital, that's going to be demoralizing. But if we can balance that with, yeah, we need to do some trimming, but then in these areas, we're going to project growth, then I think that's going to be a much more acceptable message to give to our employees. So bottom line for the month, we lost 613,000. I'm going to spend time making sure that I'm comfortable with the numbers, not just the totals, but where they line up individual lines. And we'll continue to report on ideas that we have for cost savings, and I'll talk about that more in my report.
Okay.
So any questions?
Thank you.
Thank you, Bill. You want to just go right into your CEO report?
Do you mind if I?
Follows? No, please join us.
So first, I want to say thank you for giving me the opportunity to be part of this organization, to be part of this so very special point in time. So when I was in Libby, Montana, I had the opportunity to be part of a team that designed and got funding approved for a new hospital, but I didn't get to build it. Happy to say 2 of my grandkids were born in that hospital after it was built. So I didn't get to build this one, but I get to be part of stabilizing it. And so it's a very special opportunity. So thank you for giving me this opportunity. I'm going to use what I call the stoplight approach. So on most of the topics, unless it's just general information, I'm going to tell you whether the light is red, yellow, or green. So red means until you tell me differently, I'm not doing anything on this. So I'm going to raise issues for you, and I'm going to tell you, I need direction from you. I need a decision from you, whatever it might be. But you know that I'm not working on it if it's red. Yellow are the things that I'm really working on. I need to study it more, and yellows will turn into either green or red. Sometimes with your input, sometimes I'll just say, this is something we need to do. And then green are things I'm telling you up front, I think we need to do this now. Unless you tell me otherwise, I'm moving forward with it. So I think that approach should make it clear what my strategy is. And then you have a chance at any point to change the color of the light. Okay, so throughout my report, I'm going to say that the light is this, the light is that. I try not to surprise the board. In my experience, even good surprises can be stressful. So I'm going to try and not surprise you. And one of the things that I want to figure out is how do I communicate with the board in between board meetings and obey the spirit of the open meetings law, the public communication, without endangering the letter of the law, where I tell you something that really needs to be confidential. So just know that that's something that I'm aware of, and I want to try and figure out how best we can do that, because I don't want to wait until every board meeting, even though we have a lot of board meetings. Sometimes even a week is a long time to wait. Yeah, yeah. And then you'll see that I break my reports down into 5 categories. I first talk about employees, then I talk about medical staff, then I talk about finances, miscellaneous catch-all, and then executive session. So that's the sequence of the report I'm going to give you tonight. So starting with employees. So today at senior leadership meeting, we started a process where we're looking at the on-call, the callback, and the supplemental pay policies. And so when I wrote this report, it was before that meeting today, and I was thinking, we're just going to change operational elements of the policy. We're not going to change money. So I just need to inform the board this isn't something that I need to get permission on. Based on the conversation today, that may not be the case. We may want to make some changes as far as some of the dollar elements within the policies. So I'm going to move that one to a yellow. So once we figure it out, and so now, did we say we're doing a special meeting?
Yeah. Yes.
Special meeting, yeah. So we're going to do a special meeting in the next week or two where we're going to look at all the different policies that affect this. We're going to look at what current trends are within the healthcare industry. And then we're going to also look at the realities of living in rural America. Because if you have someone in Marbleton on call, how do they meet? Right now, it's a 20-minute limit. 20 minutes is too short. It needs to be at least 30-minute callback. But those are all things we're going to talk about. So we're reviewing the policy. I found that some departments who are taking call aren't being paid for it. IT is taking call, but they're not being paid for it. And that's just not right. So that's one of the things we're going to fix. And we're going to make sure that the policy is really clean. We're going to define which departments need to be on call and which ones don't. So that it's not at a department level that it's decided, it's at an organizational level. So a lot of work is going to be done there. And you can expect to have a report back on that one before we move forward. Another yellow light, we're working to clear up confusion regarding our call center now that we have a 24-hour ED coverage model. So that one's yellow, we'll be reporting back. I know this doesn't come as a surprise to you. It came as a surprise to me at how rich our benefit package is. And it comes at a cost. And so I'm not suggesting that we make a change. I'm just saying that as we look at our profitability, our cash flow, all of that, we need to be cognizant not only of where we're at, but as we move forward, any adjustments we could make that aren't going to risk our ability to recruit and retain. Because in a small community, benefits are a big piece of recruitment and retention. And right now you have one of the best attractants that I've ever seen, and that's the retirement program. This is just fabulous. So as I say, it's not something that today I'm recommending a change. I just felt the need to emphasize. One that's red, but we're actively working on is our healthcare insurance renewal. So we're going to be proposing changes to our healthcare insurance, and we're going to have that ready, if I remember, by the October board meeting. Is that right? Yeah. So a couple of things that we're exploring the idea of moving to a self-funded program. So right now we have this thing where Blue Cross is responsible for part, we're responsible for part. The problem with that model is that any excess that's in the program at the end of the year gets split, and Blue Cross gets half of it and we get half of it, even though they've already been paid all of their money. they get to keep half of our money. That's the way I view it. In a self-funded program, we would have it all. Right now, the level at which we are funding is much higher than our average expenses. Now, health costs are a roller coaster. You have high one year and then low the next year. So I understand we need to do a 3-year average. That's typical. But I believe that we should be able to move into a self-funded program. We already have something in the neighborhood of 250, 300,000. Does that sound right? That we can use to start to fund our reserve. So I just wanted to prepare you. That's part of what I think we're going to be bringing to you is a recommendation to move forward. We're also going to be having changing the benefits such that we're incenting our employees to get their care here. So now that we have new services, and I'll use mammo and MRI as an example, those are expensive services for our employees to go somewhere else. We keep them here. It doesn't cost us nearly as much to do it ourselves as it does to pay somebody else. So we're going to try and have a different, a more attractive benefit structure for care that's received locally. And then let me see the other things about that. Oh, our current responsibility threshold is $40,000. That's fabulous. I haven't had 40,000 at a hospital in years, maybe decades. 70 to 80 was normal. I've been as high as 120. So we actually have a little bit of room there. The higher you have it, the lower your premium is. So I don't mean to telegraph that I'm planning to raise it, but if we need to raise it in order to make the numbers work, we have room to do that. The other thing I want to make sure that you understand, and I know that we, in some respects, compete with the schools and the county, at least for some employees, and the benefits that they have are even richer than ours. But for a single employee, their monthly healthcare cost is $25 monthly. So when I was in Taos, New Mexico, for Cindy and I alone, we were paying about $300 a pay period. For a family here, $150 a month. $150. I mean, that's just rocking. And we haven't had an increase in premiums in a while. I'm going to recommend an increase, even if it's only $5. If you don't do increases for a long time, then people get used to no increases. And so you need to do that increase, even if it's a little bit, just so people understand that costs go up, their share of those costs need to go up. Again, I don't know what the specifics that we're going to recommend are, but those are all things that we're working on. And our plan is to have a proposal to you in October.
Bill, sorry to interrupt you. With regards to the self-insurance, we have 2 other CEOs who've just been through it. So I definitely want to set up a meeting with you and I with them. One was done recently, the other one was done about 2.5 years ago, and both have been very successful. So I will set that meeting up with those 2 CEOs as well.
Excellent. Thank you. And Jan, when we get that set up, make sure that Lindsay is part of that since she's been actively involved in it. Okay,
sure.
Thank you. So on the Foundation Executive Director, Public Relations Director position, so Greg had signed, let me back up. Carrie had asked to go from a part-time position in marketing public relations to, is it part-time or PRN?
Yeah,
PRN. I'm talking about you.
Yeah.
And then she wants to contract with the foundation board for the fundraising side of things. So I've already talked with the president of the foundation board. We need to continue that conversation and figure out what that's going to look like. So again, I'm just letting you know that's a yellow light for your information. Another yellow light, job descriptions. It's my understanding, as we saw tonight on the board agenda, that the board approves all job descriptions. I would tell you in my experience, that's very unusual. There are some job descriptions you need to own, if you will. Mine, compliance officer, CFO you're usually involved in, because while that one may not report to you, it is so important to you. And then chief of staff or CMO. Those are ones that typically boards have a voice in. But for you to be approving housekeeper job descriptions and stuff like that, I would argue it's not a good use of your time. So while I'm not asking for it tonight, in October, I am going to be asking that we change that one. So we can have a list of which job descriptions the board wants to see, and everything else we will use an internal process. So I want to give you a month to think about it, okay? Let's see. And then I'm going to be bringing to you, this is another yellow light, a proposal for an employee, what am I calling it? Employee referral bonus program. So this is paying our employees to refer other employees. So if you're a nurse and where you came from, you knew a nurse that you think would be a good fit, rather than paying a recruiter, why don't we pay our employee? And then they actually have a vested interest in making sure that new employee is successful. And so this is going to go from everything, housekeepers and dietary people, all the way up to physicians. So this is a program I'm going to bring to you. It will more than pay for itself. But again, just to let you know, that's one thing that I'll be working on. Contracts. So there are a number of contracts that need to be reviewed. Oh, sorry, I'm shifting to medical staff now. So a number of contracts at senior leadership today. Dr. Burnett had a conversation about some of that. And then I had a meeting this afternoon with Ryan. And not that his contract is under discussion, but we're using his newly negotiated contract as a template for others. And so one of our other ED providers wants to have the contract reviewed, so I'll be, scheduling time there. That one, the light is red. And then we also have a provider that we've been in conversations and have negotiated a contract, but there are a couple of hiccups that I need to talk with you about in executive session. And Lena and I have had conversations about this, also talked with Ryan about that today. And so I have a specific plan I'm going to suggest to you after we come out of executive session, okay? Schedules. So again, we talked at senior leadership today. It was a very good meeting, wide ranging, and we're using a new format, the typical old business, new business, but then we're adding a parking lot category so that topics that we can't work on today, but we don't want to forget about, we're moving into the parking lot. So if I remember, we had 3 or 4 parking lot items already that we've identified. But we talked about physician schedules. And so with Dr. Burnett, I want to have a meeting with the medical staff to talk about our schedules. Certainly want to talk about the staffing model that we have for the emergency department. That's one that's had a lot of conversation. I learned a lot from my meeting today with Ryan. And so you can expect, I don't think I'm going to wait until the regular October meeting, anticipating that we're going to have special meetings. I'm wanting to bring to you a different staffing plan, but I want to make sure that I have appropriate communication with the medical staff before I recommend that. Let's see. Volumes. I want to create a monthly tracking tool that looks at key statistics that need to be monitored by the clinics. And so this is something that the doctors need to see, staff needs to see, administration. So it would include things like patient satisfaction, number of appointment slots that were available on a day, number that were actually used. And we also want to track no-shows and add-ons so that we can actually see how our volume is flexing throughout the day. We want to track overall patient no-show rates. I want to track chart completion, as well as timeliness of that completion. So want to have this report that really is a good dashboard for us on how we're doing in our clinics. And as I say, I want to have that conversation with the medical staff so that this isn't something that we're mandating to them. This is something they help us develop, something that would be useful to them as well. And then part of this is I need to understand what tracking tools we currently have in place. And as I mentioned, Dr. Burnett will be important in those conversations with the medical staff. And then one that you need to be ready for, again, this one probably I'll bring to you before the regular October meeting, but we had an ultrasound. So each of the clinics had their own ultrasound. One of them died. And if I got this right, I think the one in Pinedale died and they stole the one from Marbleton. They borrowed the one from Marbleton. Both the clinics need to have
Words are important.
ultrasound machines. It's becoming more and more like a stethoscope. that it's just a vital tool for the physicians. And so Lindsay and the team are working to give me options for getting a replacement unit, but I want to make sure that we don't have a Chevy and a Cadillac. We need them, because otherwise I'm wanting to make sure that the capabilities are similar. I'll just say it that way. So that's the end of medical staff. So finance. So Press Ganey contract, this was a green light. Back in December of 21, we signed a contract with Press Ganey to be our patient satisfaction company. We needed to expand, and that was just under $9,000. No, just under 10,000. We needed to expand it to include hospital, and the expansion was about 9,000. So either way I looked at it, just the amendment is 9,000, or the total contract is less than 20,000. So I'm meeting both the spirit and the letter of the $20,000 limit. So I've gone ahead and signed that one so that we can get the interface built, and that is already, if I remember right, it's starting early in November. Another green light, it's my understanding that the process was already started to cancel our external Ask a Nurse program. So we're going to move forward with that. And once we identify the dollars associated, I'll report that to you. And then we're going to be having a series of meetings with the appropriate folks to make sure that we are rock solid regarding our billing of patient claims. What I have learned is that when we converted to Ocean Epic, everything was put on 100% hold. Now, that didn't mean that we weren't billing, but it meant that we were reviewing everything before we went out. Well, it seems as if the communication about taking that hold off has been inconsistent. Some people thought it was still there, some people weren't. So as I've looked at the number of bills that have been going out, it's been going down. Now, part of that is because we don't have the Medicare, Medicaid number, so we can't be billing any of that. But part of it, I mean, we got a call from Blue Cross saying, why aren't you sending us more claims? So I was part of a meeting today. I've already had a conversation with Dom and Patrick about this. And so part of what Dom described is steps that we're taking to get us back up and then keep us where we need to be as far as billing. The other thing that I want to say is I think it's really important that we pursue a revenue cycle manager or revenue cycle director, but a leader for that department. And so Lindsay already has a batch of resumes. Some of them might be old, so she's going to go back and see how many of those are still interested. And then we're going to try and accelerate getting that position filled. So I said that. So critical access. So one of the things that we're going to have to do, and sponsoring hospital may not be the right way to say it, but when the critical access program was originally designed back in 1998, I think it was, Montana was a big piece of that because you remember, oh, now I'm blanking on his name. It was right there. It'll circle around in a minute. But the senator from Montana that was finance committee chair for many, many years, he took the lead. So the Montana Hospital Association played a key role in designing it. But the idea was that little hospitals sometimes needed a partner in a big hospital to help them with things. And specific things that they talked about was oversight of credentialing, oversight of peer review, oversight of quality. And so this isn't a management connection at all. This is, and typically you do it with whoever you're transferring patients to because they want to keep you happy. So we're going to identify who the best one for us, who's willing to do it because you don't pay money for it. So we'll make sure that we have that done. And then the other thing that we're going to have to do, the board is going to have to make a decision to formally pursue critical access. We need to be able to include that with our application. So we're going to be developing a resolution, whereas, now, therefore, that we'll bring to you, and we'll have that to you no later than the October meeting, so that we're ahead of the game for making that application. Again, so those are both yellow things. I'm trying to let you know all the different things that are being worked on. By the end of October, and this one might be aggressive, maybe it needs to slide a little bit, but I think I need to give suggestions about how much we need to adjust our budget, and keeping in mind these different topics. So number one, we need to be able to cash flow, including servicing our long-term debt. And so I'm not just thinking about how do we get to critical access, I'm thinking beyond that. Two, we need to have manageable level and number of employees. Three, we need to complete additional aspects of the campus construction. And I'll be talking about this a little bit more, but the specific example here is build out of the surgical space. We need to address retasking our vacated spaces, buildings. We can't just let them sit there. And then the last thing, and I know people will say I'm crazy for talking about this, we need to talk about saving money. We need cash reserves. And so figuring out how we have that balance. And so, you know, I typically like to think in terms of thirds. We use a third, so assuming we have a positive bottom line, a third of it we use for the employees, a third of it you use for capital, and a third of it we put into savings. It doesn't always work out into thirds, but you first have to have that bottom line. So all of that leads me to two things that you may say I'm crazy. They're red, but I think we need to do a facility master plan. I know we just opened a building, but I think we need to look at this differently now that we have 4 distinct service lines on 3 different campuses. So we've got resident care, so skilled nursing, independent living, and I'm going to argue that we need to think about assisted living. The second business line is emergency medical services. Third business line is medical clinics, so physician offices, as well as our urgent care or same day care. And then the hospital, inpatient, emergency, ancillary, and then under the hospital, just because I had nowhere else to put it, I think we need to start thinking about temporary housing options for staff. So as we're bringing people in, it just kills me to have to pay hotels. And I know we have a rockin' deal with a local hotel, but wouldn't it be so much better if, so just for example, we've got a lot of space at the Sublette Center. What if we turned just part of that space into a dormitory? You know, we would have 6 rooms, 8 rooms, whatever the number is. That would go a long way to address housing issues. I did that. And then the second thing that you'll say I'm crazy about, but I think we need to be talking about creation of a strategic plan. So as we look, so in my mind, facility master plan and strategic plan go together. One is a space thing, you know, what are the facilities you need? And the second thing, what are you doing in those facilities? Even if we don't get them completed, I think we need to start thinking about talking about, while everyone catches their breath, we needed to do this planning for what's the next step. Foundation. So this one was an automatic green light because I read in the minutes from the last board meeting that foundation funding requests are going to be as Carrie described them. So I'll work with the leadership team to develop a capital budget that then is brought to the board for approval. And then from that budget, we're going to pick which things we think are appropriate to be funded by the foundation. And so what I would like to see us do is to give them what I'll call a capital campaign project, whether it's a short one or it's a 3-year one, but a big one. And then we have smaller ones that we fit underneath that could be more piecemeal. So going to be working with the foundation board and this board on that. Oh, and this one is a thinking ahead. If we haven't already started planning for it yet, by around the time of 1-year anniversary, we need to be thinking about the new cost of service contracts on equipment. So the MRI is under warranty right now, no cost. That warranty is going to run out. And I don't know, we may have negotiated longer warranties. And if we did, that's wonderful. But at some point, we need to be prepared for big number service contracts that are going to be new expense items. And we can't wait to be surprised by them. So I'm just putting that on the list so that we're not surprised. The Rural Health Transformation Program that has been mentioned for you. So I was under the impression that the number was much bigger. I actually attended one of their online sessions yesterday. And so Wyoming has about $500 million spread over 5 years. I plan to attend an in-person one. And with the nursing home move being shifted, I'll be able to go on the 30th. I think it was Lander, wasn't it? Lander is the closest.
Yes, sir.
So that's the one I'm going to go to. I don't know that they'll say different things in person, but I'd want to make sure that they don't. And so the suggestion that I have is, what do you think about having some sort of a brainstorming session here? And so I have 3 different options. The first one, we do a community-wide brainstorming session. With the time that we have, that's probably not realistic. Second one is we do all healthcare providers, so dentists, chiropractors, people that we don't usually think is coming under our umbrella, but people that will be involved in these programs. Do we do a session? And I'm thinking next week. This needs to be quick because, as has been mentioned, this timeline, state is wanting to have their application done by the middle of October. I think early November is the actual application date, but they're pressing middle of October. And then the last one would be just us session. So board, medical staff, leadership. So that's one thing I'm going to ask you, which way you want to do it. And then I want to plan for that next week. I want to make sure that 2 things. One, that people feel like they had a voice. And I want to make sure that we didn't overlook anything. You know, someone may come in with a really great idea. So at the end, I'll ask for your thoughts on that. This is a fast-moving state-level project. My fear is that we're going to do programs that aren't sustainable. Too often I've seen that where big buckets of money, and we do these things that sound good, feel good. So a specific example, mobile clinics, that was mentioned in the call the other day. Mobile clinics sound like a great idea, but Gallup, they bought a 5th-wheel trailer and equipped it with an X-ray machine and bought a big dually to tow it around, and patients didn't buy into it. And so it was a great idea, but we ended up not using money very well. So I'm hoping that part of the money will be able to be used for brick and mortar, stuff that will last. And so things that, you know, could we get money to convert the Sublette Center into assisted living? That would be a fabulous project. Could we get money to help reduce our debt, our long-term debt? I don't know, but I really think that having a conversation with folks would do us well. And now I'm at miscellaneous, so I'm winding down. So Sublette Center move, you already heard about it, so I don't need to talk about that anymore. We got our temporary license renewal. So I really appreciate the way the state has worked with us on that. We didn't have to do anything. They took care of it entirely for us. So the state has really been good. But one thing, and so again, this was a green light. We've heard that sometimes the state perceives that too many of us are calling them with questions. And so they're not sure who the right one to talk to is. So what I'd like to do is create the expectation that within the organization, there may be few exceptions about people that already have a project or a relationship, but in general, people don't call and talk to the state without clearing it through me, so that we make sure that we're coordinating all of this. So on that one, I'm assuming the light is green unless you tell me otherwise. I think that's what the state wants from us. So again, I'm just letting you know. I'm going to be working with the board, with senior leadership, and with Jan to develop a list of people that I need to meet with. So as we've already talked about, we've already started the senior leadership team meetings. Over the next month or 6 weeks, I want to have one-on-one meetings with all department heads and key members of the medical staff. And then outside of the organization, I want to meet with the county commissioners. And so if they want to meet individually or if they want to meet as a group, but one of the things I'm going to be asking them is how often do they want me to come and talk to them? Do they want me to attend? Do they meet weekly?
Bi-weekly.
Bi-weekly. So do they want me to attend once a month? Do they want me to sit in all the time? How often do they want updates? Same thing for city council. I want to meet with city council. I want to find out how often they want communication. So I'm working to either build or repair, whichever the case may be. I don't know. So I'm just saying I want to build that relationship. I want to meet with the school superintendent. I want to meet with the chief of police, sheriff. So if there are other folks that you think I need to be meeting with, let me know, let Jan know. But during this first couple of months that I'm here, that's the time when I can start to build those relationships. Let's see, I think you already know this, but following every regular board meeting, I'm going to create a 10 to 12 minute video doing a summary of the board meeting. And I'll talk about the board went into executive session to talk about these topics. Same things you guys include in your motions. There's already a process, and it's a really cool process where there are potlucks at the hospital afterwards, and then a couple of employees present what they heard at the board meeting. I'm not wanting to change that. I think that's a great process. My videos are designed more for the community, so that they can't say, you never tell us what's going on. So we're going to post these on our website and on YouTube, so that folks will be able to see them. This first one might be a little bit longer given the topics in my report. By the October meeting, I want to at least have a draft organization chart to talk with you about. As I see it, part of my job is not just dealing with issues today, but creating a stable platform for the permanent team that's going to be here. And so as I look at the org chart, that's the way that I'm going to try, and this is the way most hospitals are organized. Every hospital has its unique approaches, but I want to have that conversation with you. So that's a yellow. And then space, I've already talked about space, but while we wait for the facility master plan to be done, this one's also yellow. I think we need to start talking about, are there little things we can do to optimize some of the vacated space? Because it just seems a shame to me to let space just sit there. And as you know, empty space just deteriorates. It goes faster than occupied space. So, and that's all I have for you. In regular session, I do have a nice little list for executive session. Questions? I'm happy to answer any questions.
Quite comprehensive and informative. Thank you.
Yes, thank you. Yes, thank you.
What's the question?
Of information. No, I think I'm just soaking it all in. Processing it. I got my notes. Thank you.
Yeah.
No, I appreciate it.
We can't let our foot off the gas anywhere.
Keep it coming.
Okay, thank you.
Thank you, Bill.
I would ask one question, Bill, if you have any particular requests of us.
So if I were to say a big picture, I need to help you move from a daily working board to a governing board. But, and I think differently about this today than I did when I was first talking about the job. I need to be slow and patient with that. Because as I have learned, the degree to which the board has been integrated in the construction project, you in particular, for me to just try and come in and say, nope, can't do any of that anymore, it all needs to come to me, that just doesn't make sense. So I'm not even going to suggest that. So like I did with job descriptions, topic specific, I'm going to bring recommendations to you where you can change, let go, however you want to think of it. So it's not anything we're going to do quickly, but that will be one thing that I'm going to work with you. It's good for you, and I think it's good for the organization. Does that make sense? Okay.
Good approach.
Yes.
Thanks.
Thank you, Bill.
Thank you.
Okay, moving on. We will go to old business now. And the first item is approval of payroll and bills. Everyone have an opportunity to review check register and the associated board required bills that are needing approval for the month. questions from anyone? Everybody has all of the information?
Madam Chair, I would move to approve payroll and bills for the month of August 2025 in the amount of $1,861,926.49.
Okay, thank you, Kenda. We have a
Madam
motion
Chair, I'll second.
and a second. Taylor, thank you. A motion and a second. Are there any comments or questions from the board? Okay, put it to a vote then. All in favor of the motion on the table to approve payroll and bills in the amount as set forth, please say aye.
Aye.
Any opposed? Motion carries. We have, I think the number is different on, I believe we have 8 invoices on our electron diligent and 7. So just one of
There's two ARC ones.
Oh, yeah. Okay. That's the difference. I just recognized it and thought, okay, just wanted to draw attention to it. Yes, of course.
On our meeting last week, I guess. You had mentioned going back to a procedure where all of the department heads are reviewing and approving. I guess, has that process been implemented yet with these, and have you reviewed all of these?
Yes.
Okay.
So I'm now reviewing all of the invoices, and anytime I have a question, and accounting will tell you I have more questions than they like, but I get that answered before. So I can report on the specific one, Apogee, that we had the 3 invoices from last time. So the 30,000 and the 40,000 both tied directly to the contract. So I've released those for payment. The 172,000, I couldn't figure out how it tied to the contract. So I have talked with their controller. She is supposed to be sending me information that will explain the formula for how, especially the first large numbers were calculated. So I still have that check on my desk until I get that information. So that's a process. Anytime that I have a question, I make sure that I get it answered before I bring it to you.
Thank you.
And a second. Are there any further questions or concerns? For the motion on the table to approve all invoices over the $20,000 mark, those in favor, please say aye.
Aye.
Any opposed? Okay, motion carries. Thank you. Next item on the agenda is delegation of authority that we promised to revisit. At last month's meeting, I asked the board to please spend some time looking at sections 1 through 5, I believe. Yes. To determine if we are ready to have some discussion about changing some of the parameters in the delegation of authority, or where we're at with that. We have some proposed changes that I'm assuming came from you, Bill.
That I'd be happy to offer comments on.
Okay, absolutely. I understand that Lena also has some information about the historical values that the board had requested earlier from some of the other hospitals. She has a little bit more information, so maybe I'll give Lena and Bill the opportunity to discuss their information before we dive into deeper discussion as a board. Sounds okay with that?
Yeah.
Okay. Maybe Lena, do you want to go first, since this is kind of a historical discussion? And then we can hear from Bill regarding his proposals.
Sure, I'm happy to, if that's what the board would like.
So as I have previously mentioned, I think it was last month or a couple of weeks ago, I can't remember which meeting it was, but have been discussing for quite some time that I have called some of my colleagues that work at other hospitals or hospital districts to determine what they do and how they kind of handle the delegation of authority. And so I've reviewed their bylaws because that's where it's specifically addressed to determine, how it is they are delegating. And as I had mentioned, it is a wide variety. There is a small hospital that had a threshold of $5,000 that the CEO or administrator was required to run by the board, clear on up to $500,000. So quite a wide gamut, if be, of the authority. There was also there's a hospital in the northern part of the state that did not have a dollar amount set, but was more focused on contracts or medical provider contracts, and allowed the CEO authority to authorize or to sign provider contracts up to a certain amount or less than 2 years. So I'm happy to provide the board like with the specifics, but not quite sure if you want me to go through all of those details or what the best use of the meeting time is, Madam Chair.
Well, I guess I will ask that of the board. And does anyone wish to have any deeper information than that from Lena's research? Or is everyone comfortable?
I think currently, especially just because it sounds like there's definitely not a typical, with those wide ranges, and so I think that's kind of conversation to determine what's important and what works for everybody.
Yeah, the only place you're going to see a lot of consistency is like if they're a Banner Health system, right? Like all of those hospitals are consistent and so forth. But other than that, across the state, there was no black and white, like consistent, everybody does it this way. It was pretty obvious across the board that it was very different. Everybody handled it very differently. And I would remind this board as well, and I told Bill this too in my first conversation with him, no one has ever done what this board has done before. You are building a hospital literally and figuratively from the ground up, right? So there's no right or wrong answer into how you do this. I do agree with Bill that for longevity purposes and just for all of you to have a personal life at some point in time, it is the hope that we move more from being so deeply involved to a governing board. It's just, how do you get there? And I agree with Bill too, it needs to be done gently. Just because historically we've been burned a few times with it as well. So keep in mind that it's not right or wrong. It is what's your level of comfort for this particular board. And again, nobody else has ever done this before. So it's okay to gently do it, or it's okay to jump in with both feet, just as long as the board is comfortable.
Thank you, Lena. Okay, Bill, do you want to speak to us about your proposed revisions?
So I appreciated Lena's comments, and I'm in full agreement with what she said. I'm going to start first with the philosophy that I bring to these conversations. In my experience, it's not important who signs a document. What's important is who approves it, who has the authority to approve. And so again, from my experience, I've always been the signer. Because what an auditor will look for is board minutes that approved the $250,000 purchase. They don't care who signed the document. And so it was with that thought in mind that I brought the draft that I did to you. And forgive me, Cindy says I go way too far with my editing. She says I'm a frustrated English professor. But I made the document flow to me in a way that made more sense rather than the multiple columns in it. So the first part, what is the topic? Second part, actual signature authority, but then it talked about who actually approves it. And then the last part is, and who's involved in the decision. And so the first 5, and I actually split one of them, that's why I had 6, are some of the big things. So if you're talking merger, disposal of fiscal assets, clearly that's board stuff. So the board approves it. Now, my job is to bring resources to you, options to you, but clearly those things are yours. Once you get down to things like an agreement with a nursing program where they're having nurses come, that's not anything the board needs to be involved in, because all you're wanting to make sure of is that you have your risk covered properly. Do they have the appropriate insurance? Do you have the roles and responsibilities defined in the contract? All of that administration can do for you. So that's why you'll see that it says that I signed that kind, and it doesn't say that the board approves it. So it was sort of that mindset that I brought to this conversation, that the signature is not important, it's the approval. And so I tried to be really clear in the presentation in that middle column about who's actually approving it. Because for the most part, most of these things were pretty big deals. And from my point of view, most of those fall to the board. And then since you haven't had much time to think about my version, and if you would want to get more details from Lena, I would recommend, I'm not going to push you that this is something you have to decide tonight. So what I would suggest is think about it, talk about it, and then let's go to the next batch.
Mhm.
And then when we have the whole document done, you can approve it, if that makes sense.
That's right where
Yes.
my head was also, Bill, so I appreciate that.
Yeah.
Okay, thank you.
Mhm.
So board members, what I was trying to compare these side by side last night and it wasn't working very well.
No. I tried doing a red line and I just was making way too many changes.
Yeah, understood.
I think this is a good starting point for discussion, though. The proposed changes, it's really appreciated. Just kind of the columns of it and, like who signs and the review process and who owns it. I think it's a great foundation to start deeper conversations.
I agree with that as well. I had kind of wondered some of the things that we physically sign, if that is necessary or not. What the risk is if we don't do it. Maybe that's a question that I like the concept, as you said, that if we're approving it as a board, then that's in minutes. And
Yeah.
if you or a CEO was to sign something, that's what an auditor is. Or whatever. I did have a question on the property leases and the consulting and contracting agreements. You have kind of like that 60,000 threshold. Is that like, where do you come up with that number? Like, is that something where you have, that's been the case in the past for you? Does that just seem like a good breaking point?
So where I came up with the number was 5,000 a month.
Okay.
And so I'm thinking in terms of if we need to rent an apartment and it's going to be 1,000 a month, especially if that's budgeted, I don't think the board needs to, I would mention it to you, but I don't think the board needs to. So that's where the 5,000, thinking that if we have what I'll call a lower level project like that, especially budgeted, and in my mind, expenses that are budgeted are much different than unbudgeted expenses. So if I have, at other hospitals, I've had pharmacy bills that were over $100,000 routinely, but that was budgeted. And so the board didn't get involved in that. If we had a $200,000 bill that went way outside of normal budget, then we would bring that to the board. So that's one of the variables I would ask you to take into consideration. Budgeted and normal expense versus unbudgeted, unplanned expense. But 5,000 was my threshold. Just because I thought that was a realistic number for a lot of lower level projects. Does that make sense?
Madam Chair, may I ask a question on that subject?
Of course.
So Bill, I think that's a great idea. Do you intend then to include the word budgeted when you're talking about property leases? So like within budget or what have you? Or will that one just be read as is?
No, I'd be happy to add that clarification. Because as I say, I think that's an important distinction.
Yeah, I do too. That's why I asked. I think
Yep.
that's a great distinction that you've made.
I am absolutely open to most of these changes as well, Bill. And I like the fact that you have noted that they still need to come to the board for approval in most cases. And I would just like to say that the signatory authority, because we've had several interims and gone through periods where we didn't have anyone,
Yep.
that's kind of why historically that fell to the board. And the USDA required it when our administrator at the time walked. They required us to become responsible for everything signatory and down. So financials became very, very important to them at the moment. We went through an audit with them and they said, you will sign and review everything. And so I think I'm okay with a lot of this as long as we have the opportunity to approve. And so.
And then I don't know if it was in this category or not, but Lena mentioned medical staff contracts. I have always taken the view that medical staff contracts are brought to the board, not the document itself. What I typically do is I provide an overview. So I would say, we have a contract for an internal medicine doc. It's been reviewed and approved by legal. It follows our normal contract template. We have made sure that the compensation is competitive and appropriate and fits within the confines of our current medical staff pay structure. There are no unusual elements of the contract. I would ask for board approval. That's the way that I typically would present. So and I know Lena and I may view this differently, but in my experience, some doctors don't like too many people knowing what they make. Because even if they're being paid fairly, it's big dollars. And a lot of people don't understand big dollars. So that's the approach that when we get to medical staff, I think the board needs to approve it. They'll rest on, Lena has reviewed it, I've reviewed it, and we're making sure it's completely legal.
Bill, you and I do agree on it. It's unfortunate that the Wyoming Public Meetings Act allows the public to request those contracts. So it's kind of where our hands are tied, unfortunately, by that, because I do agree that it should remain private, but it doesn't.
My only other comment as well is regarding county contracts. I would ask that the board remain signatory on county things just because historically speaking, we've had to negotiate and navigate so many things so deeply with our county commissioners that in that respect, I think it's important for our board to retain, kind of hold the line there.
Mm-hmm.
But that's just my opinion, certainly not, something we can discuss. So. You guys over here? Any thoughts in particular on?
I'm in alignment, Bill, quite a lot. The philosophy of if it's in the budget, then get it done, and it's our obligation to know and approve the budget, and then turn things on what's your job. Right. Yeah, the thresholds, we can debate about those, but I see in the plan that we're integral. You're moving us along, we're informed, make the decision, get down the road, and I'm happy with that all day long.
Yeah, absolutely. I agree with that. I agree too.
Agree as well. Only other comment I would kind of make is that I feel like just from your presentation to us tonight, like I can tell that you want to inform us of what's going on. And so I think, with all of the state kind of changes that we've had over the last however many years, it's like, how are we informed? And it depends on, the person in that leadership role, how they like to inform us or not, or, bring things to us or what. And so I think, as Jameson was kind of alluding to, like a lot of times, it's up to you to make the decision. We just kind of like to know what's going on, you know?
Because when you're asked by the community,
Yes.
if we don't know,
Yes.
we
Exactly.
look completely different. So part of my approach is I need to assure you that all the steps that you're doing now, we're doing. So you don't have to. But I make sure that you know that we're doing it.
Right, yes. So I think that's great. And I think how you've laid it out, because, you know, my concern here is you're interim as well. And, you know, when we move to the next person, how are they going to inform them?
But they, of course, are
And
gonna do it like me.
Well, and if that's the case
Build a
here.
system
that-
so great that they just
Yeah.
follow,
So I think how you have this laid out, you know, I think we're all still comfortable, but we feel like, you know, we'll still be informed and have ultimate, say, authority over certain. So if need be, and it will just depend on how those, who that next person is and how those relationships
Their style
develop.
is, yeah.
Yeah, I would echo that. You are precisely right. We are the ones that get asked at the grocery store and the post office, and
I know.
we weren't being fairly informed for a long time, so we had to take matters into our own hands, so to speak. So I
It's
think
okay
that's the
sometimes to
critical
say, I
piece.
don't know, let me check. But if you have to say that all the time, that's not good.
Yeah. Okay, so I think what I'm hearing here, unless someone wants to speak differently, is that we are comfortable with the proposals in large part that Bill has suggested to our delegation of authority, and we can move forward with the next section next month, which would be, and we'll rely on Lena to kind of clean things up and bring the two together. Lena, is that workable for you?
Absolutely.
Thank you. So next month we tackle, do we want to just tackle the entire remaining piece, 6 through 15, or do we want to just tackle 6 through 10 or 6 through 11 next month?
I think breaking it up is good. Like one side, so that way we're not trying to digest so much information and make so many changes at once. And when we do have discussions, if there's differences, we can kind of work through them without taking an hour to discuss it. I think 6 through 11 is a great idea next week or next month, sorry.
That's
So I'll do the same thing, that I'll go through and I'll offer my thoughts.
I think that would be helpful.
Okay.
Okay, so 6 through 11 for next month, and then we'll tackle the final part in November and hopefully come back in December with a revised delegation. Everybody comfortable with that plan?
Yeah.
Great.
Okay. All right. That puts us at new business. And now we need to have some discussion that we kind of dove into a little bit last week regarding our processes for credentialing. So Bill kind of described his experience in credentialing and the board's level of involvement. And then Lena spoke to us a little bit about why we were so heavily involved from the beginning. Again, it's been an entirely new process for all of us and the MEC committee. So I had kind of asked you guys to think about that and be prepared to discuss that tonight, whether we would like to move forward with a different sort of process as a board, or if we're happy where we're at currently reviewing 2,000 pages of credentialing. Or if we want to meet somewhere in the middle. There were several loose suggestions. So yes, please, Bill.
So if you want to still have someone do it all, also speak to that, I would suggest that you have a rotation. So you're January, you're February, you're March, and then you report to the board that you've looked at them all. So all 5 of you every month are looking, but then that would be what I'll call the hybrid between all of you are looking at them all.
Well, I think if I remember correctly, Jameson is on our credentialing committee. Which, sorry, Jameson. Sorry, I was just thinking about that the other day, and I thought, I think we did
I'm
that.
signed right now. I'm not reading these anymore.
I get the meeting invites, but I'm not.
So if you put it in 3 different
So-
buckets, leave it as it is, go completely the way that I've seen it, or somewhere in the middle. My suggestion would be do the somewhere in the middle.
Yeah.
Because that way you're not letting go and the board member then still is seeing it, but you're relieving most of the board of most of that burden of spending so much time. And then you can do that for a while and see if that's enough relief. And if that doesn't work, then you can talk about other options.
Yeah. Yeah. I like the meet in the middle. Lena, you had some thoughts about this from a legal standpoint too, that I know you just wanted to make the board informed of. So
Again, so spoke with friends across the state that represent hospitals just to kind of see what everybody else was doing. Again, I've for 20 some years have represented hospitals in negligent credentialing claims, which is kind of where my war stories come from and why I'm always a little goosey about this. But you've got the hospital over in Rollins where they have the option for both. Their chief of staff presents an abbreviated version to the board, but has the full credentialing packet available if someone wants to review it upon request. Sometimes the board feels it's necessary over there to review the entire packet, but mostly they go off the recommendation of the credentialing committee. So that, that's one way of doing it. Weston County, they are provided and review the full packets. I don't know what their volume looks like though, as far as credentialing. Hot Springs is very similar to the hospital in Rollins. They have access to the full credentialing file, but rely on the credentialing committee and MEC recommendation. The hospital a little further south follows very similar to what Bill said, where a board member sits on the credentialing committee, and then the board hears the credentialing committee's recommendation and MEC, more of an abbreviated version as well. So there's lots of different ways that you can do it. In credentialing, it's not necessarily the decisions that are made, but more so the process, right? The process is what is the most important, and that the process that is adopted or approved by the board is the one that is followed to a T. Like that is very, very important. Credentialing for hospital districts is a non-delegable duty. So it's something, unfortunately, you guys are stuck with. But it's coming up with the process that you're comfortable with. And I agree with Bill's approach. I would recommend that you slowly let go and work through that, only because, again, our credentialing committee is brand new. This process is brand new to both the credentialing committee, the MEC, and the board as well. So the board is welcome to come up with, whatever process that they are comfortable with. I also have been given some kind of templates or forms that credentialing committees and MEC can present to the board if that's the route that the board would like to take. But I'm happy to work with Bill or work with the credentialing committee or however you would like us to do that so that we can come up with a firm process. Does that all make sense?
yes. Thank you.
Again, it's a lot of information to throw at you guys, but the biggest thing you walk away from is that the Board of Trustees can't delegate that credentialing approval. So that's something that you guys have to be really, really firm on that process.
Yeah, I completely agree with Lena. If I could just add that many of our hospitals follow the avenue that you first mentioned, Lena, with regards to the chief of staff and having a summary, but obviously all the full background is there, but the medical staff committee has already had that meeting by the time it gets to the board meeting. The other thing that I just wanted to add to what you said is 100% correct. Is the process part of it. And the other very, very important part of it is actually how it's handled in the board meetings. So, actually just, the process of how it's actually handled in the board meeting itself. So that's just another area we must just make sure we do 100% correctly.
Thank you, Dom. Okay. How would we like to proceed, Board?
I like the thought of somehow a summary gets to the board, right? The whole packet's there and somebody read it, but we get to the place where the summary makes it to us and then we can dig in if we want to, because there's something that of note, or it's a clean review and there's nothing to worry about, right? So, and I get we have to exercise that discretion. That's our responsibility. Of course, I I need some guidance on what are the red flags and what are not the red flags. It's like, oh, he didn't do that. Well, I forgot to do that once, versus, oh, there's a wrongful death suit. What happened, right? So maybe we need to, I guess from my view, I need to be taught maybe what's a red flag and what's not a red flag. What are things that we shouldn't approve? And then get to the place where we can have a summary to work from, and then I think we get down the road.
I'd be very happy to ask Carolyn St. Charles to give you that assistance if you like. Spend some time with you.
That would be maybe a great board education topic for next month.
Yes.
So that would be lovely.
No
I
problem.
like too, but I do think it's important for the board to remain somewhat active in that process, at least to some extent. So I do like the idea of rotating board members, whether it's two of us take the first quarter and then, we alternate by quarter, maybe not by month. And then we swap every quarter just to, kind
I
of.
like that idea.
I think it's good for us to be educated more than anything. This is a process.
Well, and with that education, we're also learning more about it, like what their discussions are, what, could have been a red flag, how they maneuvered that conversation, what did they look at? And then that also keeps us where we've done that due diligence on our end, at least the rotation, someone's seen it. And if it maybe needs to be a more in-depth concern that we discuss as a board, then we can.
Yeah.
So kind of like a hybrid between the two, like the rotation and the abbreviated, but I definitely like the idea of having that education next month.
Does the MEC produce a summary after they go through the credentialing process? Is there some sort of minutes that are provided that?
The minutes are kept in credentialing committee.
Okay.
And then those are forwarded to MEC for approval and there's discussion. One thing that's been very helpful for us in this whole process is that we have the benefit of having legal counsel during those meetings. With regards to the process, we, members of the credentialing committee, each independently review the applications. And then we have a general discussion of who has questions or concerns. At that point, if there's those credentialing applications, we have concerns, then of course, our credentialing committee goes into executive session to discuss those concerns. So the concerns per se aren't listed in the minutes. We then come out of executive session and take action whether we want to approve or table. And Lena can explain to you, we've been through this with a number of candidates. It's a very serious thing to deny credentialing application. So we have to take that in mind. We seek Lena's guidance on some of the information in there, whether they be malpractice suits or other civil actions or whatever that's been taken against the provider. So we take that all in consideration, and our saving grace is the fact that we've had Lena available to guide us through that, because we may not understand the language, the legal language regarding a malpractice suit, and we can get an explanation thereof, and then we make a decision how that impacts moving forward. And I have to tell you, it's been quite a challenge, specifically with Telerad. I don't know the specific numbers, and I know Dr. Hasty's on the call, but it's amazing to me, well over 50% of our Telerad applicants have had a malpractice suit. So we have to take that into consideration as well. But having said that, we also have to take proper consideration if we deny privileges and what that means to that individual. And one thing we're discussing now, it's not part of this discussion, is what was touched on last time with respect to Intermountain Healthcare and pediatrics specifically, in accepting some of their information by proxy, which shortens our course, but we know in that situation who we're dealing with, what type of organization, and how much they vet the individuals that they've already approved. So that's an ongoing conversation. So yeah, there are minutes of credentialing meeting. There's not minutes of thinking of the executive sessions involved. And then that's passed along to the MAC. With the MAC, there's not the at-length discussion like there is in the credentialing. There's 3 members of the credentialing committee that are members of the MAC. So we're rehashing some of the old things. But the members of the MAC independently review those credentialing files too, and have the opportunity after they're presented by credentialing to forward any concerns or comments, positive or negative, before the MAC finally makes the decision to motion that it goes to the board.
Okay. So what comes from those committee meetings wouldn't necessarily be information that a board member or 2 board members could take in conjunction with a packet and say read through to get a better understanding if they have
based on
questions.
what Lena just said, I think there's a process that we can review whereby we can formulate a better, more extensive summary to present to the board. We haven't been tasked with that yet. It is a learning process, but I like that idea because it does give the board more useful information in terms of questions and concerns. And of course, all those will be done in the board's executive session.
Yeah. I like that.
I would prefer that method. I feel like, I
Yeah.
think that the expertise clearly lies with the credentialing committee, the MEC and Lena. I mean, you guys have all the knowledge to make a recommendation. I don't feel as a board member, I can add to that. So I think a summary, I recognize that as a board, we have to oversee it and approve it. But I'm not sure that there's anything that most of us could add to that process you already have.
You know, I like the hybrid model that you have the chance to, as a either individual or group of 2 or whatever, to go through those and maybe ask specific questions in executive session after reviewing our summary. But I do think, like I just said, I like the idea of getting help moving forward to provide an adequate summary for the board.
I think that would be really helpful.
I agree.
Okay. Is everyone on board with that? No pun intended. Okay.
I would just ask too, if, if the MEC is comfortable with, this changing process as well. Now that we've been through however many, I know there was kind of a concern that, when we first started this new, and there was a little bit of comfort with the board.
I can give you my opinion in that regard, but of course I can't speak for the MEC. We have had conversations with that, and I think moving forward, that's a conversation we need to have at our next credentialing committee. And I think Lena can help guide that conversation.
Okay, so we've got it decided on that end. How do we want to handle it as a board? Do we want 1 person to review quarterly, 2 people every 6 months with rotations?
So are we still reviewing the entire credentialing packet or are we reviewing a summary?
We're reviewing a summary with the ability to go
To
through
access
the.
those.
Gotcha.
Okay.
That's my understanding.
That's what I was thinking too.
So then your question is if we want a board member to sit on the credentialing committee and attend that.
No, just to review in full and
Okay,
review
review
their
in-
summary every month and make a recommendation to the greater board. So that we're not all reviewing every month.
When we first started the credentialing committee and had a board member appointed to it, we were credentialing providers in the clinic, and it was
Right.
much less an extensive process.
Much less volume.
I do welcome Don's suggestion that we have, in terms of the next board meeting, to have a informational presentation on credentialing. I think that'd be a good idea.
Yeah, great.
We can all learn something.
Yeah. Like it. Well, there's 5 of us. There's 12 months in a year. I would suggest we assign someone quarterly. But
Yeah. I think that's right.
are you okay with that? Okay. All right. Thank you. Good changes.
And
Good
hopefully
changes.
it's gonna be easier the second and third quarter. First quarter is
Yeah,
gonna be more difficult.
yeah, yeah.
Stress.
Yeah.
Jameson hasn't resigned yet.
Okay. Bill, do you want to talk to us about the rural health transformation funding?
So I covered that in my.
You don't have any more to
I don't
cover?
have any
Okay, all right. It was a separate
Unless-
agenda item, so I wasn't
Right,
sure. if
unless
there
you
was
want
more.
to give me direction as far as what sort of brainstorming session you want to have.
Oh, yes. We were,
Madam Chair, I just have one comment to that, because I know Bill mentioned he would like to, and understandably so, expeditiously look at that. But it is going to be a challenge if you're going to be considering outside ancillary services, be it dentistry, chiropractic, whatever, to try to get them to participate by next week. It's going to be a challenge doing that.
Yeah.
With their schedule allowance and so on. Just something to think about.
yeah. I think
I
it
like
might be
the
hard,
idea.
but I like the
I think
idea
it would be
too.
good to have them included, to feel part of that and offer some good suggestions. I think that would be very good.
Did you have something to say, Dawn?
Oh, well, it was also the directive of the state. So they asked hospital districts that were on the call. I'm sure if I misunderstood, Bill will correct me, to look outside of just your organization to your community. So
Right.
I think you.
I think we should make the effort,
Right.
even if it's, you
Yeah,
know, not
give them
received.
the
Yeah.
opportunity, and if they can't make it, yeah, but at least we.
I think it's really important for community engagement, especially
Yeah.
timing wise right now too. So
Okay.
I think that's great.
So we'll move in that direction.
Are you okay with that?
Okay, thank you.
Yeah, thank you. All right, there was a FOIA request, and it's my understanding that there is a response that has been prepared and presented. Is that correct, Lena? Or
Madam Chair, the response is being worked on. It's due tomorrow. It is quite voluminous. So I will be reaching out to Mr. Harrell to discuss how to handle that piece. But yes, it is being handled.
and we're abiding by the parameters that the board set in place a long time ago for such large requests, correct?
Yes, ma'am. We are following that policy. Absolutely.
Thank you.
Mhm.
Oh, I can't remember, but it was, if they needed printed, there was a cost associated and
Fee associated with it.
yeah,
Okay.
fees associated with the
Yeah.
amount of time required beyond a certain level. Yeah. So I just want to make sure we hold, they stay steady with that.
Do we as a board get a chance to see what has been sent?
We have not done that in the past. We've never been presented with the responses. So, and this request was specifically for all texts, emails, and everything. So I don't know that would be, what would be the legal recommendation there, Lena? It's not something that we've had that
So
before.
yeah, so just to be clear, in my production of a response, to request for all information pertaining to CEO candidates, quite a bit of it has to be redacted because CEO candidates have that right to privacy, right? And so I have to redact their names. I have to redact all identifying information. There was also a request for communication with legal counsel, which obviously I'm not going to produce as well because that is protected by the attorney-client privilege. So it's a little bit complicated at best, given the fact that I have to work within those parameters while also complying with the request. If the board is, wanting to see that response, I am absolutely happy to produce that. It is the attachments that become a little bit hairy, only because of the volume, right? So whenever you're requesting emails and so forth, they take up quite a bit of room as far as storage. And so producing those is when it gets hard. Does that make sense?
Yeah, it does. I just, think it kind of comes back to the comment earlier, like you get asked a question in the grocery store, and if this information is going out to the public, who knows how it's shared and
Sure.
want to be caught off guard by anything that's being sent out that we're, as the entire board are unaware of.
Sure, absolutely. I will represent to the board that there are no surprises. Every email included all of the board members. There was not like individual emails in between or, amongst board members. It was the entire board every single time. The thing that I am most hesitant about is the production of the CEO candidate's name or identifying information. So if the board, would like to see exactly what is produced, I'm happy to provide that. And we can figure out, how to get those voluminous attachments to you. That's not a big deal.
I'm not interested in, I don't think I'm interested in, yeah, I trust you, Lena, to put the response together, and I'm not interested in filing through it, but if you guys are, I think sounds like she's willing to provide.
I hate to make more work for you, Lena, but I do think I would like to see how that is presented and going out.
Yeah, absolutely. My only hesitation is I need to speak with Brett, who I see is on here. Fantastic, because Brett's going to have to help me figure out, just from an IT perspective, like how exactly to produce it and to get those things out. So I'm happy to provide it to whoever would like to see a copy of it on the board.
Thank you, Lena.
Yep. It'll be a lot of redactions.
That's fine. Yeah.
Just for transparency, I would like a copy as well.
Sure. I think probably, and Brett, I really do apologize for calling you out. I think probably the best way to do it would be to have like a share link or something like that that would contain the documents or the emails, but we'll work that piece out.
Yeah, Lena, I would recommend that you share it back to the board the same way that I shared it to you. I don't know if you have your own Microsoft 365 platform, but that would probably be the most effective and efficient way of doing it.
Okay. I love, Brett, that you have that much confidence in me. But absolutely, we'll figure it out.
I'm happy to walk you through it. It's pretty simple.
I know. You're so good about that. I appreciate that.
All right, next item on the agenda, we're done with new business. So next item on the agenda is an executive session. And I believe we have multiple topics to discuss tonight in all regards: personnel, real estate, contracts, and legal. So I would ask at this time that we do a brief 5-minute recess, maybe bathroom break, but I need a motion to go into executive before we do so.
I would motion to go into executive for the purpose of personnel, real estate, contracts, and legal.
Okay, we have a motion and a second. All in favor, please say aye.
Aye.
Any opposed? Motion carries. Come back in 5 minutes. Okay.
I don't know where. I did bring M&M's and Skittles. It's not a big bag, but
Oh, my God.
I just grabbed something.
Did not. Yeah, Dr. Brett's on a diet now, so we all suffer.
I'm just practicing somewhat of what Dr. Berger talked about.
See that one. I would. Yeah.
Hey, Tanya, I'm looking at her name and I reached out to you. So I forwarded that to Brett, that I got. And Brett said, this is not spam. It looks like Mr. Ziegler is using AI to take notes during the meeting.
Yeah, it's that Read AI.
I just confirmed he's